services or our health outcomes. So this current Minister of Health in around 2010, 2012. Okay, so this was 2012, 2011, 2012, when he was the Minister of State. When he was Minister of State under Professor Onyebuchi. I don't know if we remember back then, Professor Onyebuchi from Ebonyi was the Minister of Health. So Professor Pate, who is the current minister, initially he was the Executive Director of the Primary Healthcare Development Agency, NPACDA. So it's good for us to remember some of these names, NPACDA. So he came up with the program, the idea of the midwife service scheme. So the point was that based on evidence available globally, women die if they don't have access to care that they need, either during antenatal or when labor sets in and they cannot be taken to a hospital or a clinic to deliver. So a key problem was that there is something we call skilled birth attendants. So a skilled birth attendant is someone who is trained to a level of proficiency to be able to provide or supervise delivery. So usually midwives, medical doctors, most of them, of course, gynecologists and obstetrics and O&G. So those who are trained to a level of proficiency because they understand the birth process and they are able to, so if there are complications, they may be able to know what to do or they refer to the next level of care. And based on research, majority of women who die during delivery, a key issue is if there is maybe prolonged labor. We know, many of us know the complications that can arise, but a key reason why a lot of women die is what we call postpartum hemorrhage, PPH. So bleeding during or after labor. So a lot of women die, and if a woman is in labor and then goes to a TBA, that's the traditional birth attendant, many of them, for a normal delivery, yes, they can handle that. But when there are complications, like there is bleeding, a TBA wouldn't know what to do to reduce the bleeding. They don't know the kind of drugs that can be administered, oxytocin and all of that can be administered to reduce or address the bleeding. So most times, people who don't deliver in a facility where they have the right professionals to provide the care may or have a higher likelihood of dying during childbirth. So having understood that these are the issues, the intervention was to say, okay, let's make sure that every primary healthcare center has a minimum of 4 midwives so that they can provide care around the clock. So if you have 4 midwives, at least every 8 hours, you have at least a midwife. So at night, they can have shifts because labor does not tell us when it will start. So if labor starts in the night and there's a health center or PAC within a neighborhood, and they go there and they are sure there is a midwife, there's a chance that that pregnancy will be delivered properly. But if it's a woman is delivering at home at a traditional birth attendant place, the likelihood that there will be infection. So there's a whole lot. So that intervention was like to ensure that the right set of health staff are provided at those facilities. And then, so they also connected, there's what they call the hub and spoke model. So we have 4 PACs that are connected to a general hospital. So if at the PAC they are having a complication that the midwives cannot handle, there was emergency transport arranged with some private, like Nigerian NURT, I think they are called, to help ferry the woman to the general hospital for emergency care. So that was what the program was about. So when that is the SHOPI, it was like an extension of the midwife service scheme, but it's the same program. The only thing was that they added some additional components to the program. For instance, there is what we call conditional cash transfer. So to incentivize women to be coming to the hospital for antenatal. So if a woman completes like 2 antenatal visits, maybe they will be entitled to get, say, maybe 10,000. If they complete 3 visits, a top up. But if they complete the 4, they are able to get more money. So that's like using financial incentives to improve their behavior, to change behavior. So that program happened. But after the program, so when Buhari came, of course, the program was suspended. But I was involved in a research to do the evaluation. So I'm laying that foundation to now come to what is evaluation. So the evaluation, we review the different components of the program, collected data, talked to beneficiaries, talked to those who designed the program, and it was carried out by us. We were not part of the program. So usually evaluation is conducted most times by external people because you don't want to introduce bias, but you can also evaluate yourself, a program you started, just more like when you are doing like internal audit before an external audit. So you want to make sure that you're doing the right things. But you can see the difference as it is on the slide that there are some differences, clear differences between what is evaluation and what is monitoring. And within public health space now, or development sector, we've added some additions. So beyond M&E, we now have what we call accountability and learning. So there's another component, so call it accountability and learning. But we are not going to all of that. So learning, you want to say, okay, what have we learned from implementing this program? So sometimes you just pause to say, okay, what is going on well? Because evaluation is at the end of a program. But in learning, you have periodic stops where you want to ask yourself, are we making progress? If we're not making progress, why? So you answer the why question. So you need to do what we call course correct or course correction. You want to change your strategy when you realize that if you continue through this pathway, you might not realize your expected results. So I'll go to the next slide now. So like I said, this program was about based on what I call the Basic Healthcare Provision Fund. So the BHCPF means Basic Healthcare Provision Fund. Now, we want to ask ourselves, so we have 1, 2, 3, 4, up to age. So, and then we have monitoring and evaluation just to test our understanding. There's necessarily no right or wrong answer, but can we check? So, for instance, A, counting the number of people enrolled in a program, should it be monitoring or evaluation? What do we think? Just to reach some consensus.
Then that should be monitoring.
Okay. Then what of B? Okay, so we can also use the chat box. For those, not all of us will be able to speak. So you can just say A, maybe monitoring, B, is it evaluation? So tracking the number of PACs that have received funds. Remember I said under the BACPF, monies are sent to primary healthcare centers, usually on a monthly or quarterly basis. So to track the number of PACs that have received money from the government, will that be monitoring or evaluation?
Monitoring.
Okay. Then number C, measuring the impact of the funds disbursed.
That should be evaluation.
Sorry?
That should be evaluation.
Okay, do we agree?
Evaluation.
Okay.
Yes.
Great. Okay, great. So at least we are getting the differences. What of D, collecting monthly data on service delivery?
Monitoring.
Excellent. Tracking the PAC's business plan submission. So business plan, let me explain. So under the Basic Healthcare Provision Fund, so what we work with the primary healthcare centers, just some, I know we are not discussing Basic Healthcare Provision Fund. So the idea is that at the beginning of each year, they develop a plan of what they want to do. So for instance, based on the needs assessment or baseline, they're expected to say, okay, oh, maybe we don't have delivery beds, or we don't have maybe SFIG for monitoring blood pressure, or we don't have consumables. So whatever it is, so they now have a plan. So okay, we will, maybe if they don't have, maybe they have just 2 nurses and no midwife. Part of their plan might be we need to recruit, even if it's an ad hoc staff, that is a midwife. So the idea is the business plan kind of explains or has in detail what the facility wants to do every quarter, maybe for the whole year. And then the funds that the government sends to them is to implement what they have already included in their business plan. So I'm just explaining that a bit. So for tracking PAC's business plan submission, where do we put that? Monitoring or evaluation?
The evaluation, sir.
Do we agree?
Monitoring. Monitoring.
Okay, great. Okay, thanks. Yeah, it is monitoring, because the idea is it's not about results. So
Yeah.
the difference is that evaluation speaks more or looks more at results or outcomes. So collecting data on funds, disbursement, and utilization.
That one is monitoring.
Okay. Now, attributing reduction in child mortality to BHCPF.
That should be evaluation, sir.
Yes.
Do we all agree?
Yes, sir.
Yeah, so it's evaluation because even though the time, but it speaks to like time.
Time,
Yes.
yes.
Yes, so because
Because
reduction in child mortality does not happen in a day. So you want to check at the beginning when you had your baseline data. So maybe, sorry, somebody's mic is on. Please, can you mute yourself, please? Thank you. So at the end of maybe a year, you want to check how many child deaths did we record this year? So it speaks about evaluation. And then finally, measuring the impact of maternal mortality.
That should be evaluation, sir.
evaluation.
Thank you. So you can see that we have a fair understanding now of what is monitoring and what is evaluation. So well done. I think we are making progress. So we'll now go into, I mean, I know I've mentioned some of this before, but we would look at, so what are some of the purposes of monitoring and evaluation. So can someone help us read number 1 under monitoring? That's on the left side, and then evaluation. So somebody reads 1 for program for monitoring, and then read the same but the opposite. So any volunteer, please?
Yes, sir.
Great, go ahead. Number 1, monitoring. Yeah, say, can you help us read so that I want us to be, it's participatory. I don't want to be the one reading it out.
Okay, sir.
Please
This
go
is
ahead.
Chidera. Okay.
Okay.
Number 1 here is program improvement.
Okay.
Routine information helps make the necessary amendments to the program.
Okay. And then the opposite for evaluation.
It says judgment. Make a decision about the worth of a program. Continue, revise, or stop.
So I hope it's clear enough. So when you do an evaluation, you may want to, because if you're not achieving the goal you set, there may be no need going ahead with continuing with the implementation of the program. For instance, I know under President Buhari, we had the trader money. No, so there were a lot of programs for economic empowerment, but at the end of the day, the idea is they gave some loans to SMEs and individuals to help them start businesses so that they can repay. But after a couple of years, there were a lot of defaults by the beneficiaries and all. So when you had hoped that you have a seed money that you are giving to entrepreneurs to help them set up businesses, and by setting up businesses, they will also be employing labor and reducing unemployment. And then after 2-3 years, you do an evaluation, you realize that either the people don't chop the money, they can buy cars or marry extra wives, depending, and they didn't create jobs, and they are not able to repay, because when you are able to repay, then so the repayment rate, and also by the time they did all those evaluations, they realized that this is not good investment, so we need to stop. So you stop. But if the program is making progress, even if you haven't achieved the objective, but you are on track towards achieving the goals you set, then maybe you can tweak the program, or you may need to put more money and all. So that's what evaluation helps us to do. Now, can someone read the second bullet point? That's 2 verses number 6.
Planning and resource allocation.
Yes.
Refining program implementation and also reallocate resources.
Okay. And then check under evaluation.
Advocacy. Results obtained from evaluation can be used as tools for advocacy.
Yeah, so because if you have clear results, so for instance, I don't know which example comes readily, but within public health, so family planning is seen as one of the important interventions that can be used to reduce maternal mortality, or family planning, basically. So if more women have access to contraceptives, whether short, maybe like pills, or the long-lasting ones, so if the rate of pregnancy is reduced, the chances are that the woman will survive, unlike someone who maybe has no much break between pregnancy and the next pregnancy. So if, I mean, from the public health side, there's a lot of premium placed on family planning. So even if it's like child spacing and helping one to, okay, a woman had a baby this year, the woman shouldn't get pregnant by next year. So you allow the body to recover before having the next child. So if the lady is placed on family planning, different types of family planning, they can space out their childbirth. So with that kind of evidence, you can use it to advocate. So sometime ago, we made a case. I was part of an advocacy group here in Abuja who made a case to the National Assembly that the government needs to make contraceptives and family planning, different methods, accessible to women for free, because seeing that it adds value, or at least it helps to reduce maternal mortality to a large extent. And the National Assembly, we are convinced, members we are convinced, and then they budgeted for family planning. So in a sense, when you do evaluation based on the results, if you have very positive results, you can tell government, yes, you can get value for money if you put in more money into this particular program. Accountability is there, but let me just read. The last one is for evidence generation. So monitoring provides the evidence for program improvement based on analyzed data. So for the kind of work I do, which are funded by donors. So when a donor, you write a grant, you apply for a grant, and it's given to you to implement. Apologies, they are doing some work here in the office, in case you are hearing some background noise. Apologies. So every month, we submit a report to the donor to show progress. So constantly, we have, in our most public health programs, you will have a dedicated monitoring and evaluation officer whose duty is to monitor your program, constantly collecting data from the program team, analyzing and showing you. So what we normally do, so for instance, every month we have a meeting with our, what we call our investment officer or our program manager from, so my organization, we do some work with Gates Foundation. So every month we have a meeting with our program manager from the Gates Foundation, and based on the agreement, contract signed with them, that we are supposed to achieve XYZ results. So normally, I know like I said, today is not about program design. So usually we develop a work plan of the activities that will help you achieve the results. So every month we send in a progress report that shows, if we said this month we are supposed to do XYZ activities, when we are reporting, we will say, yes, we're able to do this activity. These were the results or outputs, or what we call deliverables. So you have a clear work plan, maybe for every month, the things you need to do. Every quarter, that's like, let's say Q1. So you divide the year into 4 quadrants, 4 quarters. Quarter 1, quarter 2, quarter 3, and quarter 4. So you have specific things you need to do for each month across different activities. And then you have a way to record, and then an evidence to show that you did that activity. So for instance, like maybe for MRTB, so Madam that is responsible for managing the CPD, so we have planned out the workshops that we'll hold this year. So you want to ask yourself, did we hold this workshop? So what will be the evidence to show that we hosted this workshop? Because it's not a physical workshop. So if it was a physical workshop, we are in maybe at National Hospital holding this training, we will have like a registration, attendance register, where the names of everyone, we sign in that if it's a 2-day training, so we sign in today, sign in the next day, and on the 3rd day. So when we are reporting to the donor or to government, whoever we are to report to, so as part of the monitoring report to show that we are making progress or to show evidence that we implemented that program, the attendance register or the attendance sheet will be an evidence that the workshop was conducted. Another evidence might be like the presentations that were made, but more importantly, at the end of the program, you are supposed to also develop a report of what happened during that training. So the workshop training report, workshop training report, and all of that. So you submit that. So I'm just taking time to explain the issue of evidence generation. So based on this evidence, you can now, when you analyze, you want to know, did you make progress? So part of the evidence for monitoring training. So in some training, you do pre and post assessment. So before the training, you do an assessment. And then after the training, you ask people to check the difference in terms of knowledge gained or skills. If it's a skills-based workshop or training, you do the pre-training assessment and post-training. But for program learning, so if it was evaluation, now, if somebody was taught how to treat a patient, maybe a McKinsey, let's say for a physiotherapist or Bulgarian style, how to do a particular manual therapy. So if you did that training today or this weekend, to now check in terms of impact or evaluation, maybe after like 6 months, the same people we want to check to what extent do they remember what they were taught in class or at a workshop. To what extent are they using the skills or the knowledge they were impacted to treat patients? And then what impact is it having on patients? So that's just a broad idea of what distinction between monitoring versus evaluation. So, okay, I don't need to go into all of this, but it just gives an idea of what, so constantly for monitoring is throughout the program. So I don't know, okay, I'm using can you see my pointer? Is it showing there? Can anybody see my mouse?
Yeah.
Okay, so like this is the start of the program. And let's say this is a program that is implemented over 3 years. So constantly we keep monitoring till the end of the program. So, and at the end of the program, we now do the evaluation, We now do the evaluation. So in evaluation, because we are focused on results, So at the beginning, this is where the program, maybe say the program outcome we are measuring. So yeah, so there's something we call impact evaluation. So impact evaluation is a type of evaluation, but is a little bit more complex. Like we know about randomized control trials, like we in the hospital clinical setting, we know that RCTs are common. Maybe you want to check how, if a particular therapy, whether it's a drug, so you have the control group, and then that's the placebo group, and then the treatment group. So in a sense, when you do evaluation, you want to check those who received, for instance, let's say we are looking at health insurance. So there's something we call benefit incidence analysis. I'm sorry, my other side is health economics. So there are some evaluations we do. So if you have a program, there was a program called Free Maternal and Child Health Programs. It was implemented during the MDG, Millennium Development Goals period. And it was implemented by the National Health Insurance Authority. So after like 5 years, so I was part of a team that did some evaluation. So we did some things called benefit incidence analysis. So we wanted to check those who are the beneficiaries of the program. What sort of improvements happened in their lives? And then you also compare that with those who were not enrolled into the program. So you may be doing an evaluation of people who are covered by health insurance and those who are not covered by health insurance. So one of the things you may want to check is quality of service received by people who are under insurance or those who are not under insurance, or what we call out-of-pocket payment, because insurance is supposed to provide what we call financial risk protection. Financial risk protection speaks to like the fact that if you have insurance and you go to receive treatment, you are not supposed to pay out of your pocket, from your own pocket or your savings, because insurance is supposed to cover you, unlike someone who does not have insurance. So like my organization, they provide us pretty much comprehensive insurance where it can cover almost all types of disease conditions, and we don't pay. So if someone is on insurance and you want to check health outcomes, so there's a chance that somebody who is on insurance will have more access to health care and all. So you compare with the non-treatment group, those who are not exposed to that particular treatment. I mean, so impact evaluation is a type of evaluation, but we are not going so deep into that. So we're not going to what we call, so we discussed this past 1 hour is around just the basics of monitoring and evaluation. But for that to happen, you need to have a plan. They say for you to succeed, you must plan. So failing to plan is kind of planning to fail, kind of. So to be sure that you an evaluation plan. So most of the programs that I've been involved in designing and implementing, one of the key requirements, or even a policy. So we have the National Health Policy, we have the National Strategic Health Development Plan. Maybe I know today is not around policy or planning, but for every policy that is to be implemented, there will always be an implementation plan and the monitoring and evaluation plan. So how to implement the program is your plan, where you specify the goals you want to achieve and all of that. Then you have a separate plan for you to monitor how you are implementing that program. So that's the next thing that we need to know about M&E. So this slide, it says it is important to decide ahead how the program will be monitored and how its impact, sorry, is a mistake there, how its impact would be evaluated. So monitor and evaluate. So during the planning phase, like I was saying earlier, the team, we need to decide how the program will be monitored intermittently to know if progress is being made towards achieving the set objectives. So before you develop a monitoring and evaluation plan these are some of the things to take into consideration. Some questions to ask yourself while you're planning. First is like, what do I want to achieve? So like we mentioned initially, if it's to treat a patient, so what are the treatment outcomes that you have in mind? And then you also want to know, how do you know that you are making progress towards achieving the set objectives? And an important dimension is, what metrics do you want to use to monitor? So in a sense, like if metrics is about how to count or how to measure the progress. So there are things we call indicators. We'll come back to that. And then if you have decided on a particular metric, for instance, say, okay, the metrics we want to measure might be antenatal visits or whatever metrics we want. But you want to ask yourself, how would I collect data that will help me measure that particular metric that I am interested in measuring? And then what does this, when you collect this information, how do you make sense of it? So what's an M&E plan? Like I have already mentioned. So in the plan, usually we may not go into the details, but in the plan, an M&E plan, you can use a table to design the plan. You want to define what the program objectives are, the interventions or the activities you need to carry out to achieve those plans. So for instance, if I want to, as a clinician, I'm using not a public health program now, as a clinician, maybe my goal is to ensure that the patient becomes independent in terms of activities of daily living. So a patient who has stroke is immobilized on the bed, but now we want to make sure that this patient can move from the bed on his or her own, will be able to brush, will be able to eat, will be able to shower, will be able to move around. So those are the metrics that we want to measure, maybe after 6 months or thereabout. Now, to achieve those, we have a plan of interventions or types of therapy that we will provide to that patient. And then interventions or the activities, the program activities we want to carry out, and then indicators. So indicators are the procedures to determine whether or not the objectives are being met. So indicators are really critical for the monitoring and evaluation. We'll come back to what the indicators mean. And like we mentioned earlier, you need to collect data. So you define what type of data do you need to collect regularly for you to track progress. And then, like I did mention that in monitoring and evaluation, before it was just monitoring and evaluation, but there is, in current practice, you have accountability and also learning. So under accountability, you want to be reporting back to the stakeholders. So giving a report card, not just to a donor, but the stakeholders, including beneficiaries and all. So it's now a component of, so for instance, you do patient exit interviews, or Savicom contacts clients who come to a hospital to check how were you treated. And they said, oh, this hospital, they don't treat people with respect. They talk down on patients and all. So when they collect those through exit interview, there should be a way to provide feedback to both the patients and the hospital. So there is a place for accountability. If we are not achieving the results or we are not making progress, then it's important to also bring that to the knowledge of the stakeholders. Yeah, so maybe I'll pause to see, do we have any questions? I know because this is not a physical class, so sometimes we may switch off and be doing some other things. So do we have any questions with respect to what we have discussed now in this last 1 hour plus?
Hello, sir.
Yes, please.
Good afternoon, sir. Hold on, sir.
Now, morning, no, we never reach afternoon, bros.
Sorry, morning, sir. Sorry. With respect to this M&E, especially considering putting them into practice in clinical setting.
Yes.
Does it have a specific time, especially for monitoring? Since I realize from your explanation that monitoring has to do with tracking progress, even though, but evaluation has to do at the end of the program.
Yes.
So for monitoring, in terms of the way we treat our patients day in, day out,
Yes.
does it have specific time? Like, for example, we say there are some treatment interventions that may last maybe 8 weeks. So can we say maybe just after bi-weekly, we need to be monitoring our patient or something like that? I don't know if my question is clear.
Yeah, no, it is. So, I mean, so you need to choose. So like we said, monitoring speaks to tracking progress and is done periodically. So it can, I know, like I said, I know the clinical environment is slightly different from the program side where I work because
exactly.
So it's slightly different, but the key thing is to understand the principles. So that was why I started with the fact that within the clinic, these are things we do on a daily basis without realizing that it is what we are doing. So that was why I established that at the beginning. So let's say you are treating a stroke patient, depending on the pathology and because when a patient comes into the clinic and you do your evaluation, agree on what the diagnosis is, and then you plan your treatment program. So your treatment program, you usually have the objectives, right, my brother? So you have objectives and you set the objectives. Okay, I want this patient to be ambulant within so weeks or months. Maybe, or somebody who had fracture and then maybe the cast has been removed and they need to ambulate. So we have a fair idea of what we want to do. So maybe we want this patient to be ambulant within, say, 6 weeks, for instance. I'm just using that word loosely. Unlike public health programs may last for a longer time. But for treatment, we may say, okay, within 6 months or 6 weeks, we want this patient to be ambulant. Now, but you track progress. So for a patient to be ambulant, there are sub activities or sub goals that you set. So maybe the patient cannot sit from bed. That may be the first thing you want to achieve. From sitting up from bed, you want the patient to also be able to come down and then stand. Maybe initially with support and then without support. So maybe you have a program of exercise. So maybe sit, stand. You said, okay, the patient should do this maybe 3 times a day. You give, say in the morning, do this 10 times. Do this exercise in the afternoon. You have the repetition you want, and then the intensity, that sort of thing. So you already have a program. So the monitoring now, you can monitor a patient on a daily basis. So that's why ward rounds. So the ward rounds that happen for inpatients is a type of monitoring because every day the consultant goes with maybe the multidisciplinary team. Like when I was working in Ibobi, we used to have maybe weekly ward round, but there are some ward rounds that are daily. Maybe the house officer or the resident might do that on a daily basis. So you records, okay, patient yesterday, this was what we did for the patient. This was what they are able to do. And also you are doing the monitoring. But after 6 weeks, because the original plan was that you want to make sure that this patient within 6 weeks should be able to walk on their own or walk out of the hospital. So that review you are doing after 6 weeks can be seen as an evaluation because you want to evaluate all the things you have done to check whether you have achieved the results that you wanted to achieve. But for public health or population health programs, obviously you cannot be measuring within weeks. So those ones, a lot of programs in terms of program planning might be around 2 to 3 years or 5 years. Then you do your evaluation. So to reduce maternal mortality cannot happen a day or two. So because you count, so we do conduct like every 5 years, there's something we call the National Demographic and Health Survey, NDHS. The National Bureau of Statistics works with Ministry of Health to conduct that. So those ones are population-based surveys. So do all the mapping, go to households to collect the data, and then analyze, and then it's okay. Nigeria, this is our current maternal mortality rate. And then this is, so you compare with the previous year. So the NDHS, the National Demographic and Nigeria Demographic and Health Survey, is conducted every 5 years to track. But you can also do monitoring that happens maybe every quarter, and also I'll come back to that. But my point is that, yes, you can, what you do when you are tracking a patient on a daily, you are at liberty to choose how you do the tracking and monitoring. It can be on a daily basis, depending on the frequency of interventions you are providing. So if a patient at the acute phase or early phase of a rehabilitation program is intensive, so you are conducting that on a daily basis, then you are to monitor progress on a daily basis. But if it's like once or twice a week, then maybe after each end of each week, you want to track and see where are you. So for us, for instance, just to give you an example, so we do have at the beginning of the year, so we use a performance management system. I'm deviating a bit from program. So this is more like professional development. So at the beginning of the year, like the team I work with, so I ask each person to set their goals for the year. So by January, each person might say, oh, I'll do this, I'll do that. It's recorded. We have an online portal where people put their goals. So I'm supposed to have bi-weekly check-in with my team members that I supervise. And I also I have a boss in Washington who I also meet every 2 weeks. So we meet, it's okay, this goal you set, how far have you gone? For this program, where are you with the implementation? Are you facing any challenges? That sort of thing. So there's the monitoring for, like, under the performance management system is every 2 weeks. So each person, I have one-on-one. The people I supervise come to me. So we fix a time to discuss, okay, for this program you are implementing, where are we? We were supposed to host a workshop last week. Did that workshop hold? What was the outcome of the workshop? So that's like monitoring. And then at the end of the year, we now do a review, just like it's done in the hospital, not necessarily for, I know in the public sector, it used to be for sake of promotion. Ours is not necessarily for promotion, but the point is that you set some goals at the beginning of the year. So we have, in June, July, we do what we call a mid-year review. So mid-year review, you want to check, you might see it as a type of evaluation. So you want to check the goals you set in January. Are you on track towards achieving them? But if you are not achieving them, we may need to review the program to say, okay, maybe the targets you set for yourself was too high or maybe not achievable. So you may need to now retweak and then be more focused for the next or the last 6 months of the year. And then by December, we do a final review where we check, did you achieve the goals you set for yourself? So we have so we have what we call performance dimensions, about 7 of them. That is for every, so if you are, for instance, I'm using physiotherapy. So if you're a physiotherapist 1 and somebody is a director or principal, the expectations are not the same. So a junior physiotherapist, there will be a specific thing you are supposed to be competent and be able to do. So at the end of the year, you are evaluated to say, did you meet expectation or not? If somebody met expectation, then, so you are assigning value. That's why it's called evaluation. Yes or no. If somebody did not meet expectation, we may need to do what we call performance improvement plan in place for the next year, so that where the person performs poorly, we put in some measures to help the person improve on that. So that's what evaluation is about. So I'm trying to say, yes, that you can do evaluation on a daily basis, you can do it on a weekly basis, it can be a monthly basis, sorry, monitoring. It can be monthly, quarterly, but evaluation can be at the end of the year or at the end of, depending if it's a program that is planned for 3 years, then you check at the end of the 3 years, you do an evaluation. There's what we call post-ante. I mean, there are several dimensions to evaluation, but like I said, we're not going so deep into that. So today we want to make sure that at the end of today that people understand what is monitoring and evaluation, basically. So any other question? Or comment? It doesn't have to be a question. It can just be comment with respect to what we need to do. Or do we all understand? Okay, if you understand so far what we have discussed, maybe do a thumbs up or yes in the chat box so that I know we are all following. Kingsley, are you fine? Precious, Edson, Chidima, Abdul Malik, are we fine? Okay, so let me continue. I think by 12, we'll have like a break so that maybe to stretch, like a health break, we can just go grab water. So by 12, that's like in 25 minutes time, we'll have a quick break. Now, before you develop a monitoring and evaluation plan, there is what we call a log frame or logical framework. So the idea is you want to show, it kind of gives you a pathway, because for you to achieve a result, results do not happen by chance. There has to be a clear pathway to say, okay, if I do this, this is the result I'm expecting, and this is how I will track it. So in a monitoring and evaluation plan, you have 5 key components that should be included in the plan. First is the inputs, and so the input speaks to the resources needed or to be invested into the program. So I would want us to give us an example. So for a rehabilitation program, let's say what we are more familiar with. Let's say we are a rehab program for maybe an athlete. At least many of us watch football, or we're in sports medicine or sports physiotherapy and all. So let's say, who is the most popular footballer now? Let's say Ronaldo, yes. Ronaldo or Messi got injured while playing, maybe Barcelona, when they were Messi was in Barcelona and Ronaldo was in Real Madrid. So let's say Messi was tackled and then his cruciate ligament of his left knee was damaged and he was stretchered off the pitch. And then he's brought to the clinic. Maybe for those who work at National Hospital, I'm in Abuja. So let's say you are a physiotherapist, occupational therapist, P&O, that you are part of the multidisciplinary team. So what are the resources that will be needed for the rehabilitation program? Any examples? What are the things you will need for the rehabilitation program of Messi? Say maybe surgery is to be done and surgery has finished and the patient has now been discharged, and then comes to the outpatient or physiotherapy, occupational therapy. So what are the examples of that we can say are the inputs? Any takers, any volunteer? I can call people out too. Okay, maybe Oga Suleiman Aminu, you've been bailing us out. Can you give an example of what can be an input?
Hello, sir.
Yes, my brother.
Yes, I think cryotherapy should be one of the intervention program, if I get you right.
Okay. So what other things would you need, like the resources so I'm using the word resources broadly speaking. Okay, so
Okay.
okay, Yusuf, please go ahead.
Okay. First one, maybe human resource, like the multidisciplinary team that will be involved, the physiotherapists, the nurses, and things like that. Also, we
Excellent.
can talk about the physical resources, like what my Oga just mentioned. I'm talking about ice pack, if it's going to need a walking aid or things like that. Also,
Yeah,
maybe environmental resources, like maybe a treatment area where the rehabilitation is going to be done, or maybe theater where surgery is going to be done, and things like that.
excellent. So this is breaking it down. Those are inputs. So input can be physical resources or not. So human resource is critical for this for any intervention. So it doesn't have to be money. So I'm glad so that's clearly the inputs that are invested into running that program. So for process, we now so like you said, for a monitoring and evaluation plan. So the idea is like you have an input, a process, and then an output, an outcome, and then an impact. So for process, it says here that activities carried out to achieve the program's objective. So what may be some of the activities that you would be part of a rehab program for a sports person? So Yusuf, go ahead. Or Sule. So the different components of the rehab program. So maybe, for instance, by the time, so part of the components might be somebody who has surgery or cruciate ligament damage, there will likely be pain. So you will need to have therapy to handle that pain, both during the acute phase and then the subacute and the chronic phase. So all those things that you do, those are activities. So for, like I said, the person will also need to go through ambulation. So the walking, the trainings that are involved, so that those are the specific project activities. So I'm using project loosely. And then so who is Florence? I think you're, I don't know who that Florence is, since okay, but anyway, then you have the output. So the output, there is what we call the intermediate results or intermediate outcomes. So they are like the short-term results that contribute to the bigger results. So for a rehab program, we want to make sure, so the overall goal for a patient or a sports person who injured and then going through a rehab program, excuse me, the result will be, we want this person to be back on the pitch, playing competitively like they were before the injury. So the specific milestones, like we call them, key milestones. So maybe first might be the ambulation, whether it's able, let's say, making sure that the elbow or knee, it becomes, the mobility has improved. Obviously, when someone had an injury, undergoes surgery, and then was on bed for a long time, maybe under cast, we know that sorry guys, so there will be muscle weakness or wasting. So some of the immediate results we want to achieve will be improved muscle strength. Like I said earlier, maybe from 2 to 3, 4, and then to 5. So those specific results that you achieve that leads to the eventual goals are what we call the intermediate outcomes or intermediate results. Then, so we have the outcome. Okay, I've already talked about intermediate results, but forget this one is speaking about the population level, but I'm just looking at an individual. So to walk is one of the walking independently / running. So running will be the main result we want to achieve because a footballer needs to run around, not just walk, but able to run. So walking can be an intermediate result. The person maybe ambulating with support or with aid will be also some intermediate outcomes. But the ultimate outcome would be that the person is able to go back to training and then be able to finally compete competitively or get back to their level of fitness that they were at before the injury. So, but the impact now would be maybe at the end of the season, if Messi was scoring 20 goals in the previous season before the injury, so one impact of the rehabilitation might be, are we able to get this person back to that level of fitness so that they are able to play at the level they were playing before the injury, like scoring goals or even exceeding their previous record. So that will now be seen as impact. So impact is not measured in the immediate, but at long term. So a season for sports is a long season, like 12 months is enough to check the impact of a rehab program, or maybe over 2 years, depending on period they had the injury. So that's just an example of how you structure an M&E plan. We may not have go into details of that for somebody who is working in the hospital, but it's just to use this as an illustration of how we develop a monitoring and evaluation plan. So, I mean, this is just coming back to what we had discussed earlier. So types of input or resources can be man, money, materials, and examples. So you could see, so we just already discussed that. For like the basic healthcare provision fund, the process could be, some of the activities would be to identify the patients or beneficiaries, enrolling them, making sure that they receive the services that they are supposed to be provided for them and all. So, I mean, we don't need to go into all this, but I wanted to just use this as an illustration. So we already discussed what inputs, processes, or outcomes are. And so now, having described what are the components of an M&E plan, the next now would be for us to say, okay, what are we going to measure and how are we going to measure that? And that is where indicators come to play. So we will, okay, before I open that, can anyone tell us what is an indicator? You can use the chat box or you can raise your hand to unmute yourself if you have an idea, or just what you understand by an indicator. Hello, guys. Okay, let's see. An indicator.
Good morning, sir. I think
Good morning,
my
yeah.
simple understanding of it, indicator is
Go ahead.
okay. Indicator, by my understanding, just a reference point or something, a landmark, or you can call it a parameter. Some of things we looking out so to make our analysis. Some of the things we can look out to.
Okay. So, for instance,
come on with our
yes, so
our
for
analysis.
Instance,
that is what
yes,
I found out as an indicator.
Excellent. No, you are absolutely right. So can we give examples of, let's say we are for a rehabilitation program for an athlete who got injured. And we have already outlined that some of the main outcome or impact would be this person to be back on the pitch, playing every week and week out, maybe playing both in the Champions League and also the local league. So, but to achieve that, there are specific milestones that we want to achieve. So I know I gave a little example. So for instance, for measuring pain, measuring the mobility or range of movement of the knee joint, because if the knee is immobilized for, like we know, there will be adhesion and then some stiffness. So you want to improve the mobility of the joint. That can be indicators. You can also check muscle strength, can be an indicator. Standing can be an indicator. Walking can be an indicator. And even for walking, you have different milestones. Walking with aid, maybe using the parallel bar to start working, and then transition or move from using parallel bar to walking frame, and then from walking frame to maybe use of crutches or using walking stick, and then eventually disposing of all types of walking aid. So those can be indicators that you track. So I'm just using that loosely. So yeah, thanks. Many have already mentioned exactly outcome measures. So we have, for pain, for instance, we want to record to what extent is the pain reducing. So we have an outcome measure that we can use to measure those specific indicators in terms of pain threshold and all. So thank you guys. Yeah. So that's exactly what I wanted. So here, I mean, in this definition we have for this training, we say that an indicator is a variable that measures one aspect of a program or project that is directly related to the program's objectives. So our program objective or intervention objective is to ensure that, or to achieve independent living for an athlete who was injured. So all the different components of the performance, what they need to perform at their optimum best, can be seen as indicators. So we track those. So that helps us to see that if they're able to work independently, if they're able to do this, if they're able to do that, it will, over like a month or two, we are guaranteed that they will be able to perform optimally like they were doing before. So, but in choosing an indicator, they also need to be smart. You know, we know what, like in certain objectives, I know we have the SMART objective and stuff. So an indicator should be something that has some measure of variability, not a constant. So should be able to, something you should be able to, there can be some progression. So that's why an indicator should have that function or that attribute of variability. So its value should be able to change. Like we said, if you have a baseline level, so somebody, if it's ambulation, you can have zero ambulation, and then, but you have other, so there's some progression from lying only on bed to being able to sit, to stand, to walk, and to run, and then even to play football. You could see that there is some kind of gradation. So variability is critical for an indicator. Then the next component that is also important, or function or attribute of an indicator, is that it should be measurable. Like a goal should be measurable, and then it should also be specific. There should be level of specificity with respect to a variable. So you cannot be measuring everything. So if we are measuring ambulation, you could see that there are various components of ambulation. So we should be able to measure all of those components. So that's what, so that when you are going to kind of collectively measure an outcome, you know that those components add to the overall outcome. So variability, measurability, and specificity are at least three major components of an indicator that, so that when you are choosing an indicator, it should at least have these three and others as well. But these are the three important ones. Then, like we already said, I mentioned it earlier, an indicator must be SMART. So we know the SMART acronym. So I may not have to go so deep into that, but it should be specific, like we said before, measurable. It should also be achievable, and then should be replicable, and then time bound. Because if it's not time bound, then it's like we don't have any benchmark to use. So great. So for each of the components of an M&E plan, so there should be an indicator. So if you want to measure the input, there should be an indicator. If you want to measure the activities that will lead to the result we want to, we should also have indicators to measure that. Then the output or the result we are looking for, whether it's intermediate results, we should have indicators. Same for outcome, and also the same for impact. I think it's almost 12. Let's just pause for here. Do we have any questions? And then we can take a break for like, I don't know how many minutes, but the MRTB person, I don't know how usually the break, whether it's for 30 minutes or I don't want us to stay too long for the training today. So I want us to at least by 2 o'clock, we should be wrapping up.
Hello, sir. Yes, my question is, the SMART you say is
Yes.
it's confusing me with variability. I don't know what do you mean by SMART. Is it mean by it is a? I don't know what do you mean by the SMART. So I want you to throw much light on it, sir. Please, sir.
Okay, so can anybody who has heard about SMART goals before? Like when you want to set a goal, like maybe New Year resolution, they said if you are setting a goal, you have to set SMART goals. So can somebody tell us a bit about what they mean by SMART? Okay, Sule, I see.
Hello, sir. Yes, sir.
Go ahead.
I think SMART means objectives that are specific, measurable,
yes,
achievable, realistic, and time bound.
Excellent. So Felix, maybe if you don't mind, use an example to just illustrate that so that our colleagues can understand it a bit more. Maybe those who are not familiar with the SMART goal.
Okay, the SMART is an acronym, sir.
It's an acronym, yes.
Yes, sir. Thank you, sir.
Yeah. So maybe Sule can take it again.
Let me highlight it again. Let me put it down, sir.
Okay, yes, sir. It means objectives that are specific, measurable, achievable, realistic.
Just take it slowly, so that he wants to write it down. Yes.
Okay. Specific, measurable.
Okay. Okay.
So achievable.
Yes.
Okay, sir.
Realistic and time bound.
Yes.
Yes, sir.
Thank you so much. So Felix, you understand it now. So Felix, did you get it now? Okay, maybe yeah, so the variability, because if a variable, if an indicator is not variable, then measuring it will not be, because there's no way you can make comparisons. So if a variable is like a constant, does not change, then measuring it will not be really easy. So, but if you want to measure something, because you want to check results, so to what extent are they making, there's a kind of like a process, they are moving from point A to point B. So as that progression is happening, then there are changes happening. So that's what we mean by variability. So I think we should take a break now. Then later we'll come back to go deeper into the development.
Hello, sir.
Yes, go ahead.
Can I suggest, even though I don't know the moderator, the plan for the moderator, but can't we reach maybe like 1:45, then go for break, just like for the 30 minutes?
Okay.
Because prayer time will be around that 1.
Oh, yes. Okay, that's true.
Yes,
okay,
maybe
definitely.
1:45 we can take a break, and then maybe 1:15 we'll come back.
Okay, yeah. So yeah, makes a lot of sense. So just give me a minute. I wanted to check. Okay, no worries. Yeah. So when we say an input indicator, how do we give me an example of an input indicator based on the examples we gave before. So if I think Yusuf, hello Yusuf, you helped us say, okay, for the rehab program, that some of the input you mentioned some, like let's say for human resources for health, what type of inputs may be possible for us to see as input indicators. So let's use human resource for example. Hello, Yusuf. Or any other person. Who is Precious? You're really...
I think, sir,
yeah, go
input
ahead.
indicator will be based on competence. I think it should be on competency of the professionals or maybe healthcare providers in terms of rehabilitations and the modality they have. Modality, like equipment or tools.
Okay, so
That
how
is.
do we... So in this sense, and so just to give you an example, so for any indicator, like we said, it should be measurable. So is it something that can be counted or measured? So for instance, so if we say human resource is needed for a rehabilitation program, so could it be that an input might be, okay, we need a multidisciplinary team to properly provide this care, rehabilitation, to run this rehabilitation program. So it may be, for instance, it's okay, we need at least a physiotherapist, an occupational therapist, maybe a prosthetic, an orthotic, for instance, maybe one of each. We need, of course, you need an orthopedic surgeon and all of that. So they are clear inputs with respect to the personnel needed to provide that care. So that can be, I'm just using that as a rough example. So if we need some specific therapeutic modalities, so maybe specific input can be, we need a walking frame, we may need a parallel bar, we may need a wheelchair. So these are like inputs needed for, so they are indicators. So because if we don't have them, we might not provide the optimum care. So who is this Precious? I think you're kind of messing up the screen. Maybe somebody's child that is just drawing abrupt, that is messing up the screen. So please, whoever is Precious, kindly stop what you're doing. Yes, number of head, thanks of Saretin. Yeah, so but not just the number of head professionals. We can actually be more specific now, since we say an indicator should be specific. So specify the type of professionals and the number that will be needed for providing that care. So yes, thank you. Somebody also mentioned, Joy says tools, objective. Okay, great. So then I'm using an example that when we did this training, so then it was around health insurance. We were doing the basic healthcare provision fund. So we are training the team from the National Health Insurance Scheme who are from their monitoring and evaluation department, because they are supposed to monitor the health insurance, this basic healthcare provision program. So there are specific things NHIS was supposed to do. Just for instance, NHIS was supposed to disburse money to the state health insurance schemes, and the state health insurance schemes are to use the money to pay for services that these enrollees are supposed to they are entitled to. So, for instance, pregnant women are entitled to free maternal and child care, like ANC, delivery, and a whole lot of that thing. So here, for instance, one of the inputs, remember we said men materials can be seen as inputs. Sorry. Sorry, okay. Yeah, so for input, for instance, for the Basic Healthcare Provision Fund, so financial resources that are important, because the funds are used to buy a lot of other direct inputs, maybe to pay for salaries, to buy equipment, to renovate the primary healthcare centers and all. So those are clearly inputs. Then for the process indicator, so in the M&E plan, some of the process indicators that we identified, I mean, one of the things we are measuring. So the idea is, for the program, you need to enroll people into the program. And so the process of enrollment, we say, for instance, the percentage of, what we mean by SSHIA is State Social Health Insurance Agency that receive funds. That's for input, because money is disbursed from the Ministry of Health or NHIA to all the states. That's the expectation. So if they don't disburse money to all the states, the 36 states for FCT, then a component of the program is having a challenge, because funds were critical for providing other input. So one way to measure could be, are we disbursing money to the states? Is it done in a timely manner? So if disbursements is to be made maybe a day after government approves, so if there is any delay, it can be an indicator. May not just be the number of people, number of state insurance agencies are receiving money. We may even need to check, are they receiving the exact amount that they are supposed to receive? So that could be an example. And we also want to know, how timely are they receiving the money? So if they were supposed to receive this money 2 days after it was approved by Federal Ministry of Finance, and then disbursement is done through the central bank. So if it delays, maybe rather than getting it within 24 hours, those can be indicators. So timeliness of the disbursement can be an indicator. So beyond the fact that you are disbursing money to them, timeliness, the quantity you are sending, if you were to send them 100,000 and then you send 50, so in a sense, you're not exactly providing them the resources they need. You are underfunding them. So that can be an indicator. Then for process, so for here, one of the examples we used was the number of state health insurance agencies that have commenced enrollment, because people are supposed to be enrolled into the program. So enrollment data can also be a process indicator. Developing guidelines for how to enroll can be indicator using, so for instance, within the clinical setting, we have standard operating procedures. So if we are to treat we are running a rehabilitation program for an athlete who got injured. So there are standard operating procedures for providing the specific therapy to guarantee results that we want. So if using the standard treatment protocol so using standard treatment protocol or procedures can be an indicator or a process indicator, for instance, so that you want to know that if you follow the process like to the letter, or what we call fidelity, then you are guaranteed to get results. But if you don't, then possibly it's like if we do it anyhow, there might not, the chance of achieving the result might not be guaranteed. So the process of achieving results is as important as the input itself. So that's process indicator. Then we have what we call the output indicator. So that one is a little bit clear because when you do an activity, you want to see a result. So an output. So for instance, like within the kind of work I do, so holding a meeting or workshop is an activity that we do a lot. So one of the indicators for a workshop can be like an output, like I said before, an output from a workshop can be workshop materials, something to show that that workshop was held. Conducting pre and post tests can be an output of a workshop because you don't want to make sure that the workshop, you didn't just come there to gist and go. So if we were to impact knowledge, maybe today like on M&E, we want to make sure that the MRTB want to be sure that at the end of this training, there are objectives. We want to make sure that, yes, that everybody who attended this program would have had, even if it's 50% improvement in their knowledge base with respect to M&E. Another output indicator might be we want to track how they are using the knowledge to kind of integrate it into their practice. It could be another output indicator and stuff. So output is about results. How do you count the results? So for instance, maybe somebody is to develop a report and to print. So developing a report, you have the inputs, you need the human resource, the person to collect data and write. So collecting data is a process. So analyzing data is a process, but the output could be a report. So developing a report can be an output. You can count, is something that is tangible, like is quantifiable. So it's measurable. So if somebody is supposed to deliver a particular result, maybe, so for instance, so we hire consultants to help us do a couple of things. And what we do is that the consultancies are tied to results. So maybe I have done consultancies before. So there was a project that a UK organization, this is like 2012, long ago, they hired me to conduct a baseline survey for them before starting a program. It was a maternal and child health related program. And it was to happen in, I think, 5 states. So FCT, Kano, Jigawa, Sokoto, and one other state. So I went to Kano. One of the places I collected data was at Aminu Kano Teaching Hospital. So I had a questionnaire that I needed to administer as part of the baseline survey. So I met with the CMD then, I think Dr. Aminu also was his name. So I identified who I needed to meet to collect the data. So I was able to administer the questionnaire, also did interview. So there were specific people, because we are collecting an information around maternal mortality, use of data, and all of that. So I also did the same. I went to Jigawa, so I met people at the State Ministry of Health, I think Director of Public Health then. So there were specific people that we identified for me to collect data from them. That's qualitative data. We also had quantitative data. I also went to Usman Danfodio University Teaching Hospital in Sokoto. I met with the CMD then and some key people, I think the head of nursing, people who provide maternal and child health services. So I needed to interview those people because we wanted to know what is the current situation, like I said, baseline. So after doing all of that, I also, I think about 5 states that I went. I had a research assistant that accompanied me to help with the data collection. So after collecting all of that data, we did the analysis and then report. So the report itself is like an output from that assignment I was given. So the inputs involved a lot of things, inputs such as money for transportation, money for hotel. I needed to stay in a hotel for all of that period, money to pay stipend to the research assistant I hired. So those are like inputs. The other inputs included the questionnaire that I used for collecting data. And then the process itself, like the process of collecting data. So there should be a way. So part of the thing was I need to collect data from, so we had a list of respondents. And because the process is to collect data from specific people. So one way to measure the process is to say, if I was supposed to collect data from 12 people, or interview 12 people, did I interview those 12 people? Yes or no? So that's like an indicator. Now the other things you can also check is, did I, for instance, I mean, there was also, we also did some desk review to do, yes, so we also did some desk review to collect some secondary data about maternal mortality and all. So those can be seen as processes that will lead us to having a baseline data or report or information. So the output for the work is supposed to be having a report baseline. So there is the input, specific resources needed for doing the data collection, and then the process of collecting the data itself, and then developing a report. So that can be output indicator. Maybe not necessarily outcome or impact, because baseline is just setting a base. There is no intervention to measure, but I was just using that as an example. So for a lot of consultancies, we have, like, we call them deliverable-based indicators. So an output can also be called a deliverable. So if we hire someone to do a particular assignment for us, so at every point, we pay based on the deliverable. That's the output. So if, for instance, just an example, maybe we hired a professor at UNN to do a study for us. So the project now is to conduct a research project. So let me give you the actual name. So we, as part of the Basic Healthcare Provision Fund, the intervention was that the logic is that for primary health centers to deliver quality services, they must meet some criteria. They must have the right facilities, they must have the right equipment, they must have the right human resource, and all of that. But you also know that you need an impress. I'm using the word impress because most departments, physio, occupational therapy, the HOD would need an impress to run the department. So some money to, like a daily thing. It's called operational cost, for those who understand that. So operational cost is what you need to run a program, run an office, just the things you need on a daily basis. So from studies, it was found out that most primary healthcare centers they don't receive any operational cost either from the state government or the local government. So you go to a primary healthcare center, maybe a woman is to deliver. The woman will bring the Macintosh, will bring the blanket, will bring the scissors and everything they need for the delivery. I know some of us may know some of this. So, but it shouldn't be so. An average clinic or health facility should have the basic things that are needed that's the input. So, and it's the operational cost that they can use. So a woman needs paracetamol. So the pharmacy should have the basic or the essential drugs that are needed in a hospital or a health facility. So the operational funds and what did that. So one of the studies we commissioned was, okay, for the basic healthcare provision fund facilities, what would be the minimum amount they need to function, maybe not optimally, but at least to provide the basic services that they are not like general hospitals. Primary health centers have to provide primary health care services. So you don't need so much input. So, but what we needed to do was to quantify the amount an average primary healthcare center would require to function without having much impediment. So what we did was we had a design. So we had a professor of health economics and his team. So we agreed that the amount needed by a primary healthcare center in an urban area will not be the same for a PSC in a fairly rural area. So we did the study in 6 states. So I think I forgot the number of PSCs that were selected. So they went to collect data. Now, we ran this program, I think it was for 6 months, this research project for 6 months. So we had like key milestones. So at the beginning, like developing the research protocol was seen as an output. So when they developed the research protocol and submitted to us, we paid. Let's say we had to pay them 1 million for this project. So we divided this into milestones or milestones. So developing the research protocol, we pay. And there is an evidence. So the output is having that research protocol ready for submission either to an ethics committee for approval. So getting ethics approved is also another key milestone. Conducting a workshop or training of data collectors, and so it's also another output. And then going to the field to collect the results, the data is also another output. So we can measure that, okay, you have done this, you can tick. Doing the analysis, having like an analytical framework of analysis plan was also seen as an output. Conducting the data analysis itself is another output. Having the final report is also another output. Coming to present it to National Primary Healthcare Development Agency. So we had like key outputs at every stage, because if you don't do those, so those are the processes that will lead to having the baseline report or the operational cost report. So at each stage, you need to be sure of what output you are expecting, because if you don't have clarity of what output you need, then measuring that may not be possible. So, I'll just stop there. But the point is that input indicators must be clear. The process, that's what you will do to achieve your results. And then outputs are the specific results that will add up to give you that big result you want. Then impact, like I said, is like a longer term. You want to, like, after 3, 4, 5 years, you can look back to see the impact of that particular project. Sorry, this scribbling on whoever is drawing these doodles is not helping at all. So let me pause to see if people have questions. So your question, you can also use the chat box to ask a question. Yeah, so thanks, Oluwumi. Under service delivery, like how many patients visit a clinic per week? Yes, you are right. Yes, that's clear indicator. Any questions? You can use the chat box, or you can unmute your microphone, or you have a comment. Please go ahead. Hello, guys. Do we have any questions? Do we understand? Or should I move on? Okay. Sounds like a yes. So now, I've explained input, process, output. Now for outcome, I know we discussed it before, but like I
Sir,
said,
there's a question. There's a
okay,
question in the comment box.
okay, let me check. Okay, so it says, sir, please, what's the difference between indicators and outcome measures? So, I mean, so indicators, like I said, is like the thing you are measuring. So outcome measure, so your question, is it like outcome indicator versus outcome measure? Please, may you unmute yourself so that I understand you clearly, because the way it's stated in the chat box, it says, please, what's the difference between indicators and outcome measures? Maybe not so clear to me.
Okay, sir. Good afternoon, sir.
Yeah, good afternoon, Saritin.
Thank you so much for the lecture. Sir, at the beginning, when you asked us what we thought of indicators,
Yeah.
in the chat box, a lot of people said outcome measures, and that's what I thought too. But I said, let me wait and get what you had to say. So I thought you were going to expatiate on outcome measures and why we need to use outcome measures. But this is the first time I'm seeing indicators being explained in this manner. I can say for a fact that I do not even completely understand everything we're talking about right now. I have to still go back and do some research on my own. So as regards patient care, when they say, oh, what are the indicators for this? At what point, or how will I know that the indicators that they're asking for in that instance is not an outcome measure?
Okay, thank you.
And
Go
sir,
ahead.
I'm sorry, sir. I know that you are not done, but this is also related to my question. This impact indicator measuring the long-term effect or the end result, can we now say that in all these indicators, it is the impact indicator at the end of the day that is an outcome measure? Because the outcome measure will take baseline and also results.
Okay.
Thank you, sir. That's the question, sir.
Okay. So thanks a lot. So let's stick to indicators. So I know that within clinical settings, we talk a lot about outcome measures, right? So what are the examples of outcome measures you use within the clinical setting?
For example, back balance scale is an outcome measure. VAS for measuring pain is an outcome measure.
Okay. Other examples?
Yes. There are numerous, really. Like timed up and go test is an outcome measure.
And what does it measure?
It measures the risk of fall of an individual. The risk of fall, especially in elderly individuals.
Great. So if you
remember,
like
back balance.
Go ahead. Sorry. Continue, please.
Like back balance scale also, it measures the risk of fall of an individual also. It has items that you assess, you test patient on. So you take them at the beginning of your intervention, then at some point in time, just as if you are monitoring or at the end of the treatment. That's if you are evaluating.
Yeah, so whether we call it an indicator or measure, like I said, indicator is like a variable you are measuring. Now, so we only need to make like some clear about the difference between an outcome and an impact. So outcome loosely is the results you are measuring. So an outcome measure is a framework you use to measure a particular result you are tracking. So like he said, for instance, the pain. So if you want to measure pain, like you're treating a patient who like has back pain or any type of pain, but you want to say, okay, how do I track results or the outcome of the intervention I am providing to the patient? So you need to have a way to track or measure progress. So results can be immediate or intermediate. So the immediate result, like I was talking about training. So if you do a training, one quick result you want to check, for instance, the output, the quantifiable results you are getting after that training or from that training can be like the knowledge that you are impacting on the participants. So you have a way to measure. Like that was why I said you can use a pre or post-test questionnaire. So you administer, so we do that for most times when we are doing capacity building. At the beginning, you want to test the knowledge base of the patient, sorry, I'm using the word patient because of clinic. You want to measure the knowledge base of the participants. And then at the end of the training, you want to test them again. The same questions you used before, and then you apply. You might just change maybe the numbering and all, but the same, you're measuring them using the same scale or the same outcome measure. Because using a questionnaire is like an outcome. You want to measure an outcome, but outcomes are time bound. So it could be outcome at the end of the training. It could be a week after the training. It could be a month after the training. And then when the time is like 1 year or more, you are now looking at impact. So impact is mainly at the population level. So for instance, using the same example I'm using about basic healthcare provision from before we come to the clinical side. So an outcome indicator, for instance, that we were included in the monitoring and evaluation framework we developed for the National Health Insurance Scheme then was the increase in service utilization is an outcome, not an impact. An outcome in the sense that because maternal mortality is high, so the program seeks to increase the access that women who are vulnerable women in this sense are pregnant women. So a pregnant woman who does not go for antenatal or who is not delivered by a skilled birth attendant, like a doctor, a midwife, a nurse, or even some, oops, sorry about the noise. We are working in the office. So those, sorry guys. So anyway, the idea is that you measure results are seen as outcomes, but you can also have what we call intermediate outcome, which are like in the midterm, intermediate, and then the actual. So when I was talking about the ambulation, so we want a patient to go back to playing. So that's like the outcome we are really looking forward to achieving. But all the other additions, so maybe the pain threshold, managing the pain and reducing the pain, we have a mechanism that's like the outcome measure. We have a mechanism for measuring that. For somebody who maybe is a geriatric patient who we know that the tendency for fall is high, so we have an intervention. Maybe we are doing some rehab program to increase their I'm using the word stability loosely, but they do some exercise and all of that to make sure that their balance improves and all. So you have a way to constantly monitor the progress. So the progress in this sense, we are also calling them outcome. Like I say, outcomes are loosely, the synonym is result. Outcome measure. You want to measure the results you are focused on achieving. So outcomes can be like immediate, it can be intermediate in the sense like it just amount time. So when I use, for instance, the research project that I commissioned and a professor was working on, so those key milestones are outcomes. So we have a way to measure those outcomes that contribute to the final, like the bigger result. So you have components that add up to give you the big result. So those can be outcome measures, but for those outcome measures, there are indicators that you measure. So for instance, maybe like you want to measure pain. So you may measure, an indicator might be I think we use, sorry, it's been a while, I haven't been in the clinical environment, but when you are measuring pain, you may measure the intensity of the pain, for instance. You may measure other components of the pain that are part of that outcome measure. So you have an indicator that measures a particular, we said specific, that an indicator must be specific, must be variable and measurable. So in a sense, you can have indicators that add up to be an outcome measure. So for instance, you're looking at mental health. So they may have like a battery of questions to ask someone because you want to know their mental health status or an outcome. I don't know, but I'm just using, sorry, like I said, the focus is pretty much around the population health programs or public health program, not so much about clinical alone, but I wanted to lay that foundation. The idea is that outcome measure, yes, but within an outcome measure, it's not just one thing you are measuring, if I'm not mistaken. So there are specific components. So those specific components can be indicators that add up to give you that make up the outcome measure that you are tracking. So for instance, the quality of life score, if you want to measure the quality of life, there are different components that you measure that add up to, it's okay, maybe like fitness. If we say fitness is a result we want to achieve. So there are components that make up fitness. So if you have an outcome measure for measuring fitness, there are components of it that you need to measure. So, but in terms of indicators, indicator will be like all those components of fitness. How do you measure them? So each of those components or variables, remember we said variables, are called indicators. I'm sorry, I hope I didn't confuse you more. So I'm using an example like we have on the maternal and child health thing. So an outcome, we said, an outcome measures is a set of short-term or intermediate results. You see, we are talking about outcome, but we are here speaking about results that are measurable at the population level that the program seeks to achieve through execution of the activities that we talked about under progress. But impact is more, we are speaking about long-term now. So for maternal mortality, for instance, so to reduce maternal mortality is the impact we want the program to achieve. But there are results that are more immediate that will help you achieve the result of reducing maternal mortality. Like I said earlier when we started, for a woman who pregnant women need to go to the hospital or health facility for antenatal. So that is a result you want, because not having access to services will not guarantee women being saved from maternal mortality. So receiving services, like utilizing services, is a key indicator that you need to track. Because if you're providing services at a hospital and women are not taking them up, then that's like a waste. So what's the use doing that? So I'm just saying, for instance, those are things we can do. So you track the components of the big results that you want. Then impact speaks to the long term, a particular thing you want. So for instance, I'm trying to use examples that are population. So impact is more like at the population level. So you are looking at improving the quality of life. So people need to have jobs, people need to have access to water, people need to have good roads and all of that. Those are indicators of advancement of a country. So if you have an intervention that seeks to improve the quality of life, so the quality of life is more like at impact level. So it's like at the what we call the macro level, you have the you have the micro, you have the macro, and the meso level, like the policy level. So there are like different levels. The result is like the immediate things that you need to see change. Then those changes aggregate to give you an outcome. Then outcomes aggregate to give you an impact. So for instance, at the beginning, you enroll patients, and then these patients access services, different types of services. And because they are accessing the services, then you can reduce maternal mortality. So maternal mortality, you're measuring at the impact level because the reduction does not happen in a day, but accumulation of different results, women receiving, going for hospital, women eating the right food during pregnancy, and all of that. Women, somebody sick, they are treated. If had a hypertension, maybe preeclampsia, you identify that and you attend to that. So those are like different results that will help you achieve reduction in maternal mortality. So maternal mortality is like one big impact, is a result, but at the bigger population level. But all of these others will add to it. I hope it's a little clearer. Or do we have any other question? Okay, let me see. It says, I think. Okay, so Oxford Muzzle Grading System for, okay, I saw Oluwumi Ayinke Durojai. Do you mind talking a bit about the muzzle strength test grading system for those who don't know and what it measures? Hello, Oluwumi, are you able to speak? You can have the floor. Sorry, I'm kind of putting you on the spot. But if not, that's fine. So, Saratin, does that make sense or not?
Sir, it makes sense. I understand it a bit better now. It's clearer to me now. I think outcome measures are specifically used in a clinical setting. But for this, like you mentioned earlier, we're talking about the public health space. So it's easier to be tracking your progress in stages or in steps. So I think, sir, I understand it a bit better now from the explanation you gave. Thank you very much, sir.
Okay, you're welcome. So can you give us an example of some outcome measures that you probably use within the clinical setting, for example, so that we can discuss and unpack it?
Okay. So some of the common ones we use for pain, you can use the numeric pain rating scale for pain. Then to measure the endurance or capacity, sometimes you can use the 6 minutes walk test or even the timed up and go test. Then we use what outcome measures do we use? So we use the sorry, sir, I'm trying to remember it at the top of my head right now.
10 meters walk test.
Yes, sir. We use functional independence measure. We use the modified Ashworth scale for spasticity.
Okay. So now let's unpack one of the outcome measures. So the one for pain. So what are the components that you measure when you administer that outcome measure? What are the key things that is measured in terms of pain? Does it measure the intensity? Just list all these typical things in measure.
So that's numerical pain rating scale.
Yes.
Just measures the intensity of the pain. And it is more subjective than objective because you tell the patient from a scale of 1 to 10, you explain 1, the lowest possible pain, 10, the highest possible pain. So you explain it and then the patient chooses a number that best describe the intensity of the pain they are feeling. So that's just it. It measures just the intensity of the pain.
Yeah, so not just, when we say just the intensity, it doesn't give the whole full picture. So the intensity is like how intense this pain is, right? It's like we say measurability. Even though it is self-reported, it does not make it not valuable because it's subjective, right? No wahala. But the point is that there is so the result so in your mind, a patient comes maybe in that scale of 1 to 10. So 10 is like the highest, and then 0 or 1 is the lowest, dependent. Now, as you are treating the patient, your expectation, the results you are tracking is you want to get to 0 or 1, right? So as you treat the patient, you check, maybe depending, like I said earlier, if like you're seeing a patient daily or 2 or 3 times a week, after each treatment, you want to check. So it's an immediate result you're checking. But the bigger outcome is either elimination of pain or having the pain at 0 or 1 level from 10. So as you treat, you check. So the indicator you are measuring is the intensity of the pain, right? That's the indicator that you are tracking. So remember I said an indicator should be variable. So pain intensity is variable. So there's a variability component of pain. So, and that is the indicator you are tracking. So the pain is not, so pain is generic, but you are looking at a specific quality of the pain that your treatment is targeted at reducing. So the target is, so the overall goal of that intervention is to reduce the intensity of the pain from high maybe to very, very low. So as you treat, you test and ask the patients, okay, now that we have done an intervention, maybe you use the modality, it could be spinal manual therapy for somebody who has low back pain. You treat and they come back the next day. It's okay. Can you compare the pain as at yesterday and today? So where on this scale do you think the pain is? I might say, okay, from that 9 or 10, it's now dropped to 8, for instance. So that's some progress. So there's a measurable progress. So the indicator of intensity you are measuring or the result is to eliminate pain. So you are coming from 8, and then as you treat, you are tracking until it gets to maybe a point where there may be no more change, or it gets to a point where it does no longer interfere with the patient's activities of daily living. So in a sense, like I said, outcome is measuring results. So result can be immediate, as in now, as you just finished. It could be after like a week, you want to measure the results. So there is some time element when you are looking at result, because we said the results should be time bound. So you want to check within a week from the time you started treating, you want to check the results. So like I said, result is the same as outcome. But impact, so for an individual, when I use the example of an athlete, I said an athlete that had injury while playing, so the outcome we want, or the impact is, I say, for instance, somebody who scores goals, like the best striker in a team, scores like Erling Haaland or Mbappe at Madrid. He scores, bangs in like 20 goals or Mo Salah at Liverpool, who scores like week in, week out. So the impact on the team is high. Like at the end of the season, because of the goals he scores, they may likely win the Premiership or win the Champions League, that sort of thing. So that's the impact that you are measuring, their impact within a period of time. But they now gets injured, the person gets injured, and then your rehabilitation plan is to bring them back to a place where they are functioning exactly like before. So those are you can measure the different stages or the outcomes, the results that will put them in a position where they can make the same impact. So the impact is a bit of a longer term thing. So I'm using rehab now, for instance. So rehabilitation might take 1 year. So somebody who has spinal cord injury, like to get them back, their rehabilitation plan may be longer. It could be 1 year, 2 years, depending on the severity of the injury. So at every point, you are tracking results, but an impact you may want to measure. And so after a while, so this person, after 5 years, can they go back to working again in an office rather than be bedridden? Will they be able to go back to the office to work and become functional again, contributing to development in the society? Then that can be seen as impact, even though it's not something we measure in the clinic. So within the clinic setting, the results you can measure are outcomes, not impact. So impact is outside the boundaries of a clinic. I'm just using that in a way because what you cannot spend maybe 2 years with a patient, except for those who have chronic neurological conditions that will depend on the medical team and the rehab team for a long time. So that's a different thing. But for the results we are tracking within a clinical setting, yes, outcome or results, intermediate, longer term, but impact is how that person is contributing to society or how functional they eventually are after going through the rehab program. I hope it makes sense now. Okay. All right. So Sule, yes. So we said 12:45 to go for break so that we can have a health break, and also our colleagues who need to go for prayers can go and have their prayers. We should be back by 1:30, if that is fine, so we can go on break now.
It's okay, sir.
Thank you. Okay, sorry, 1:30, yes. We'll be back by 1:30. And then we can wrap up. Have a good time, guys. So I can also stretch and come back.
Now selected useless colors.
It's 1:30 now. Our friends who are yet to join to come back. Break is over, and it's time for us to continue with our presentation. Thank you, Mr. Abrams, Felix Ubi. We're very grateful for thus far, and we hope to continue to enjoy the workshop. Thank you, sir.
Okay, guys. So I hope we are back. Maybe we'll give people like a few more minutes. We had almost 100 people earlier, so let's give them maybe 5 more minutes or 2 to 3 more minutes. But in the meantime, if you check the chat box, there were some, so the MRTB for this workshop had also highlighted some additional things to take into consideration. So for instance, it says service delivery indicators and associated data requirements and sources. So we can touch on some of this. But like I said earlier, I didn't want us to just jump into this without laying a foundation for people to understand what is monitoring and evaluation before applying it to rehabilitation setting. So we will touch on report, health management information system. I will really dwell on that a bit because rehab, like we all know, rehab is gradually gaining attention within the health system. So the rehab management information system is still being developed. I will talk a bit on that. So what are service data, how to collect data, how to aggregate data, what sort of policies are put in place for managing data collection and reporting, the structures and functions of the health management information system, and how rehabilitation is or could be integrated. Excellent. So we're going to talk on that. Patient service evaluation, record report visualization. So there are a couple of things we can touch on, but let me quickly just wrap up and then we can, so I think we can try to use the next 20, 30 minutes to finish what we have on the slide deck. Then we can now go back to more rehab focused. And I know I've touched a bit on some of the rehab focused things earlier, but I also would like to give you a broader picture, even though it's not in the slide, of the health management information system itself so that we understand a bit more and then see where rehab, to put rehab in perspective. So let me try and, okay. Okay, let me share my slide again. Can you all see my slide?
Yes, sir.
Okay, okay. So maybe, okay. Okay, good. So, excellent. So where we were before, sorry, let me get this, because it's not showing on my side. I think I must have clicked on something. Mm. Okay, great. So I think you can see my slide now. I had a little glitch, but I think we are back. So just a recap of what we were discussing earlier. We had, where is this note? Oh, okay. My slide wasn't moving, but just to recap a bit more, because we'll come back to this. So we said an M&E plan must have these components, the input, you have the input indicators, you have the process indicators, or what they call the activities. Process indicators tracks the activities. Then the output indicator tracks the sort of results we are looking at. And then the outcome speaks more like broader, like, so we said results can be the immediate, like the output, the immediate, the intermediate, and the longer term. And then in terms of impact, we are looking at the population level or a performance level. Some may call it performance indicators, yes. So maybe some call it performance indicators. Like when we are discussing about the footballer who had injury, so the impact will be them performing very well at the performance well when they get back to playing. So just some examples, like I said, so for a rehabilitation focused M&E plan. So we have a patient, like the sports person that we talked about, who was injured while playing and then gets surgery done and now comes to a rehabilitation center. So a multidisciplinary rehabilitation center. And then we said that one of the things that you would need in terms of planning and providing this. So you plan your treatment, but the resources you need are what we call the input. So for instance, you need to plan for physiotherapy sections, like the treatment sections. Those are like inputs. The human resources, the multidisciplinary team involved in rehabilitation, all the things that they need to do to be able to carry out the rehabilitation itself. Those are all inputs, including, so the treatment you are going to provide, the things you are adding, so we call them inputs. So to the components of that rehabilitation plan, if for instance, so there will be somebody has stroke, so physiotherapy sections, occupational therapy sections, speech therapy sections are all inputs that will go in. But you need the human beings to provide the services. So the members of the multidisciplinary rehab team, they will all be seen as inputs. If you are going to do home, maybe there is the home sections or things that involve the health education. So for instance, somebody who has back pain, we want to ensure that beyond treating them at home or a patient who comes for rehab, we know that we have the home program. So the home program are all inputs on their own. Now, when it now comes to the process, so the process are now carrying out those activities. So for instance, like we discussed when we started the program, so we talked about doing the patient assessment. That is a process. Carrying out the treatment itself, that is a process. Doing follow-up, or patients coming, you are doing a follow-up and having review, that is also seen as process. So indicators would now be, how do you measure or track or quantify the inputs? How do you track the process or the activities? And then, so we've talked about input. I'm just giving an example related to rehab now. Input indicators, process or activity-based indicators, then the output, like I said, results. So for instance, if you want to measure results, maybe for instance, the number of treatment sections you have already carried out, that can be seen as an output. So in a week, you want to treat the patient needs to come twice, or you gave exercise regime, and the patient, there's a way we measure for exercise. When you're prescribing exercise, there's the issue of intensity, the repetition, how many reps are you going to carry out? if it's the weight training, for instance, what's the number of kg the person is supposed to lift? So, and how many times in a day or in a week? So those can be seen as part of outputs or results. So if the patient is doing that, so you know you are tracking. If, for instance, you gave them, they had to do exercises twice a day, and they were only able to do once a day. That's so out of two, they were able to carry out one. So that's the results you are tracking. In addition to other types of outputs that we can track with respect to like rehabilitation service. For instance, patient satisfaction. Are patients satisfied with the treatment we are providing and all of that? So those are also important. So, and that's like in terms of result. But if we now want to move a bit more, we had already discussed. So some of those outcome measures that were measured, like the visual analog scale for measuring intensity of pain, for instance, or we are measuring about quality of life, so, or fitness level. So we have different measures for measuring fitness. So those can be seen as outcomes. So indicators can be input indicators, process or activity-based indicators, outcome indicators, which look at results and all. Then there is the impact. So impact within the clinical setting, so they are loosely used as performance indicators. So, like I said, a patient who was immobilized and all, and then the impact or outcome indicator can be, for instance, the level of them performing, if it is a sports person or somebody getting back to work, like there was some sort of disability that impacted the person due to injury, and then the rehabilitation is to get the person back to work. So the performance or the impact we are measuring now would be the person going back to work, for instance, or becoming independent. They don't have to rely on caregivers or family members to brush their teeth, to help them shower, or for them to move around or ambulate within their environment. So independence can be seen as an outcome, an impact or performance outcome. So in a sense, even though public health programs or population-based programs, the impact is seen as is looked at the outcome level, as a population level. But for rehab or treatment, we can't really measure impact, but it is focused on that individual. So, but it looks like at a higher level, you're looking at functionality, being able to perform, being able to contribute to society, being able to, if they are like somebody's a husband, being able to feed and provide for the family, those can be seen as the level of impact. I hope it makes sense now for those who initially had challenges understanding. So the example I've just provided, you can see that there are indicators that are very rehab focused or clinical environment focused. So the visual analog scale, VAS, like forgotten the name, that's colleague that mentioned, it measures pain intensity. So pain intensity is an indicator that is measured, because I said an indicator can be variable. So there's like a grading scale, variability of pain intensity. So it's measurable and all. Quality of life is measurable. Fitness is measurable. So there are a couple of things. So you could see that the characteristics that we said that, or the attributes or qualities of an indicator, it must be variable, should be measurable, and then specific. And also pain intensity is specific. So measuring pain is big in a sense, but pain intensity is clear. So you are measuring. Maybe if pain, there is also the temporal component of pain. I remember during my clinical days. So maybe people who have osteoarthritis, they might experience pain, and then more in the morning when they wake up or when they sit down for a long time. So there are different aspects of pain, and you can measure specifically using a particular indicator of interest for that particular indicator. So for ambulation, like I said, ambulation is big, but we can say, okay, for patient being able to ambulate without support or without aid, that is an indicator. So because you progress from using support or mobility aid until you wean off, and you realize that when we are doing rehabilitation, we go through those phases. A phase, like I said, from sitting to standing, standing to taking walk, or even maybe stepping. So I remember patient comes out, is able to sit up from bed. That is a progression from lying prone for months. So moving the patient from a prone position, lying position to sitting position, that is a kind of like a progression. Then from sitting up on the bed to being able to bring out the legs to sit outside, sit on the bed, but outside. That is a progression. Being able to sit and then stand and go back to sit is also a progression. And then standing without support and taking the first steps with maybe parallel bra or walking frame. So you can see that there's a way you can measure something. So that specificity is what makes an indicator clear, makes it measurable. So, like I said, just forget the ones here because they are focused on the particular program we supported the Health Insurance Agency to implement. Now, we'll now go to the end of the M&E work. So now we have measured, so we have identified the specific indicators and all. So the point about M&E is like you need to collect data. So, and in collecting data, you need to collect data and then you analyze and then process the data and then make it make sense. So that's the next thing now. So within what the MRTB wanted us to discuss today is the Health Management Information System. So the Health Management Information System is that system that makes it possible for data to be collected at the facility level, and then it flows from the facility to the local government level, to the state level, then to the national. I know most of us may not be familiar with it. It's called the Health Management Information System, HMIS, Health Management Information System. Now, this system has become digitalized. Before, it was manual. So, in the hospital, we have the records clerk who keep all the data that we record in a hospital. So a patient comes, there's what we call encounter data. So each time a patient comes into the hospital or a health facility, that encounter, I'm using the word encounter, so just take note, is recorded. So a patient comes, they have a card, you give an appointment, the day they come, then they take maybe the vital signs. So there are some routine data you collect each time a patient has an encounter with a health facility. So those data is collected for those of us who work in specialized clinic like rehab. So a patient comes to physio or occupational therapy, you take records. So a stroke patient, you take the vital signs, you check their breathing rates and intensity and all of that. You check their blood pressure. And so you take some records. So those are very important because they are part of the data and health management information system. So, but now I'll go down to, because most of us work in either teaching hospital, that's tertiary, or secondary at general hospital. So I may not focus on that, but the health management information system, which is common for all countries. So WHO had laid the framework. So all countries have a health management information system. Now, at the local government level, we have the local government health authority. I'm sorry, I don't have it in the graph here, but this, I'll come back to the graph we have there. Oh, sorry, the slide. So we have at the facility level, that's primary health care, is the lowest level, or health facility level. So data, every patient, I don't know if any of us have gone to a primary health care center, you realize that they have different registers. So there's a register for antenatal visit, there's a register for immunization, and not just immunization, for the different types of antigens that are administered, for pentavalent vaccines, for measles vaccine, for BCG, for all sorts, HPV, and several of them, polio. So they have several different records or registers where these are recorded. So a woman comes for antenatal, it is recorded. So in the antenatal register, they record that this woman visited today. So at the end of every day, clinic day, so the officer in charge, so the health worker who oversees, like the equivalent of CMD at the primary healthcare center, is called the officer in charge, OIC. You may have heard about OIC. So the OIC is in charge of a primary healthcare center. So all the records are kept there. So at the end of the day, they summarize how many patients came on that day, antenatal, regular visit, maybe people who had malaria, children, and all. So they keep all of that record. So those records at that level is collated. So if you go to a health facility like a primary healthcare center, some will display them as charts, so monthly or quarterly. So you have the average number of patients that came each day and at the end of the month. So you can see whether it's rising or falling. So those records are kept there. And then from the primary healthcare center, the records are sent to the local government, health authority, or the PHC department of the local government. So all the primary healthcare centers within a particular ward or local government. So every month they bring the data from their clinics to the local government. So at the local government, you have local government, like a kind of an M&E officer who is responsible for collecting all of that data. So they now aggregate at that level and then send to the state. So at the State Ministry of Health, you have, so within a State Ministry of Health or at the federal, they have some key departments, just to mention. So you have the Department of Planning, Research, and Statistics. So within it's called PRS. Some of you may have heard that PRS. So for instance, I think in Jigawa State, the person a director of PRS at the Jigawa State Ministry of Health, I think he's a physiotherapist. I don't know whether he's still the director of PRS. So within a Department of Planning, Research, and Statistics, there is a unit or division. So they have maybe 3 or 4 divisions, but you have a division responsible for the Health Management Information System, the M&E. So you have an M&E division within any Ministry of Health, whether it is federal or state. There is a department, or not necessarily a department, within a department called Planning, Research, and Statistics, you have a Monitoring and Evaluation division. So it's this division that is responsible for collating every health-related data. So from all the local governments, for instance, here in Abuja, we have 6 area councils or equivalent of local governments. So the FCT Health Department would collate each local government will get data from all the primary healthcare centers, and it should ordinarily include the secondary facilities and tertiary, but somehow they don't often feed into that, but they're just laying the structure of the health management information system for you. Then the state collates all of that data and then sends it to the federal. So at the Federal Ministry of Health and Social Services, as it is called now, there is a Department of Planning, Research, and Statistics, and they have a few divisions. They have a division for research, they have a division for monitoring and evaluation, and then what we call knowledge management incorporated. You have division for planning, for health systems, and all of that. But our focus for today is on the division for monitoring and evaluation. This is important because all the M&E functions of the Ministry of Health is managed and handled by that department or that division of the bigger department called Planning, Research, and Statistics. So Planning, Research, and Statistics is where every policy, health policy is coordinated. So they are the custodians of every policy. Like we have the National Health Policy 2016. Developing that policy is this department that anchors it. And specifically for the health management information system, we do have a health management information policy, national policy on health management information system. So maybe you can Google that later so that you can see what are the components of that policy, because for this course today, the board wants people to be aware. So there is a policy that guides everything around health management information system. Now, the health management information system, like I said, data flows from the frontline health facilities to the local government, to the state, and then to the federal. That's like the manual process. So they have specific registers or forms for filling the actual data at the health facilities. So, for instance, there is also within this system, there is also a component of the health management information system that is for reporting disease incidences, for instance. So, of interest to us would be hypertension cases that pass through the system. So number of patients that come for hypertension, maybe hypertension clinic, or people whose threshold of blood pressure is above, their records are above the threshold, and all of that for patients who have diabetes. So there are some specific things I'm just saying for us who are rehab. So the types of patients or conditions of interest to us, or the, excuse me, the kind of conditions that we provide care for. Obviously, I'll come back to rehabilitation management information system, but the point is that for every country or every health system, there's the health management information system. So the key takeaway is that this is a system for collecting all health-related data. So, for instance, every month, so it's called routine and administrative data. So you're not conducting any research. It's just every day a patient comes, is recorded, there's a register for patients, and then at the end of the day, they collect all of that. So, okay, hello, Lububatu, please, can you mute yourself? Suleiman Lububatu, please mute yourself. Okay, good, thank you. So I'm taking time to explain from the frontline facilities to the local government to the state. So at the state Ministry of Health, they have what they call the HMIS officer. That's like the Health Management Information System officer. So the HMIS officer at the State Ministry of Health is responsible for overseeing the collection and archiving of data coming to the state. And then he transmits that data to the Federal Ministry of Health every month. So it's a monthly, so at the primary care level, data is collected every day. Then the accumulate that every month. They send to the LGA. Then the LGA puts all of that together, aggregates all of that, and sends to the state. And then the state transmit to the federal. So at the federal level, they have an overview of all the data coming from the 36 states and also FCTs. That is like 37 states in principle. So it's a whole lot of data. So before, they were all manual. So you feel this, so they have a form for like collating the data. So the registers are available at the primary care level. Even in hospitals, we also have registers where like at the antenatal clinics and all of that, but I'm not focusing on hospital. I'm just trying to like say the primary care system, which is the basic or the foundation of the health management information system. And it gets to the federal. Now, over the years, so we've moved from manual system to a digitized system. So the digitized system, there's a software called the District Health Information System, DHIS. Please just take note. I wish we have a chalk or board where I can be writing this. District Health Information System. So we have the Health Management Information System, HMIS, is the system for the country. Now the platform that is the digitized platform that the Health Management Information System runs on is called District Health Management Information System. So it's a software for managing the health management information system. It was developed in Sweden. There's a group there, I think it's a university in Sweden. Yeah, Sweden or Norway. I think it was Sweden or, yeah, probably Norway or Sweden, but in the Scandinavian countries or Nordic. So they developed that software and then it's used globally. So sometimes you will hear about DHIS2. So the version that is currently being used is DHIS2, number 2. That's like second version. So that is you can maybe use your phone to just check. You will see, it's just that you have to create an account. They give someone login, but they have a back end where all the raw data comes to, and then there is some analysis that can be done. Let me give you an example. So if you want to know the number of patients with hypertension that we are attended to across the country, you can pull that up from the DHIS2. So, like I said, aggregates all the data from the primary care level to the state and then to the federal. So just a click of the button and the Federal Ministry of Health can give one that data. And then the indicators of measure. So for instance, if you want to know about the number of patients who attended antenatal, so antenatal care visit is an indicator. You can track that using the health management information system. You want to know the number of cases of polio. So you know that the acute febrile illness is recorded. So at the PAC level, if a child comes with, and there's a notification about that, so there is another component of the health management information system that is for disease surveillance. Is a module in the DHIS2. So it's for recording or reporting, sorry, for recording and reporting all cases of infectious diseases of interest. So if there is Lassa fever outbreak, there is a system for reporting that. So most of the infectious diseases like measles, like yellow fever, Lassa fever, a whole lot of them, there is a mechanism for reporting that. So I hope you, if you have any questions, let me know before I continue.
Hello, sir.
Yes. Yeah, go ahead. Somebody said, excuse me, sir, please, do you have a question or you want to say something?
Yes, sir, it's a question, sir.
Okay, go ahead. You just muted yourself. I said, go ahead.
Yes, sir. I said the meaning of SHF, primary health care / SHF. Somebody asked.
SFH that I know is an organization, is an NGO called Society for Family Health. So I don't know if that's what the person is asking about. But what I was saying, if it's related to the health management information system, I said is the district health information system, DHIS2. So I'm just typing it in the chat box just for, so is it the digital platform upon which the health management information system runs. So two key things, there's a health management information system, health management information policy, national. You can Google and then take your time to read. At least it's a policy framework for running the health management information system. And then the district health information system, sorry, DHIS, not systems. DHIS, district health information system is DHIS. So it's a digital platform. So the Ministry of Health manages that. The M&E division of the Federal Ministry of Health is the custodian of that. But the software was developed in the Scandinavia and it is an amazing thing. So for instance, I was just trying to say, so last week, oh no, we are still in this week. So this week, from Wednesday to yesterday, we hosted Dr. Pate, the Minister of Health, hosted what we call the joint annual review of the Nigerian health sector. And the idea was, okay, so we had one last year, November last year. So as part of the reforms, the idea is to say, where are we? Have we made progress from last year? So there were some indicators. Remember, we discussed about indicators. So there are some indicators to track progress. So for instance, under maternal and child health, there were indicators like antenatal, service coverage, how many women are utilizing primary health centers, how many women are attending antenatal care, how many women or how many children are immunized. So for instance, there's what we call zero dose. A child who has never received pentavalent vaccine is seen as zero dose. So zero dose is an indicator for tracking immunization coverage. So the number of children within a catchment area. So if you have within, let's say in Kano, and you have like 2 million children. So to track immunization, you want to know how many children have never received immunization, any antigen before, whether polio or measles or penta 2 or 3 or BCG. So all of that, the records are kept by. So for immunization related data, the National Primary Healthcare Agency also has an M&E unit under its own Department of Planning, Research and Statistics. So all government and ministries and parastatals would have a Department of Planning, Research and Statistics. And then M&E unit or division would be domiciled within this department. So, and everything about data, they are responsible for that. So it's good to have this. So going back to what I was saying, so during the week, the stakeholders from all the state commissioners of health and key people at the state level came to Abuja, in addition to partners like us, came to review the performance of the health system between, like, what have we achieved between last year and this year. So for instance, under insurance, as of last year, I think the coverage for health insurance, in this sense, how many people who have any type of health insurance, whether it's the federal one or the state level one or private insurance. So NHIA now tracks that. So the states, all the state health insurance schemes, they send in the data of people who enroll into the health insurance. So that's an indicator. Insurance coverage is an indicator. then they share it with NHIA. NHIA, that's National Health Insurance Authorities, no more scheme, collates all of that to now know how many Nigerians are covered by health insurance. About 2-3 years ago, it used to be said it's about 5% of Nigerians have insurance. But currently, during this year's review, the figures have now improved a bit. So I think they said about 21 million or 22 million Nigerians now have health insurance, unlike when it was 10, 15 million. So you see how the health management information system is used to track specific progress being made. Same for antenatal care. So service indicators looked at how many children were immunized. So immunization coverage is an indicator. Zero dose, children who don't have any is an indicator. So when you conduct like polio campaign, those immunization days, they also track. So how many children are eligible to receive vaccination within a locality or catchment area? So children under 5 years old are expected to receive immunization. So if the projected population of children may be 3 million, then your health management information system will be interested in how many children out of that 20 million have received immunization, complete dose. So you know that we have the schedule of, as health workers, we know that children, when they are born, they take immunization at specific periods as they grow until they are 5, and of course, measles when they are under 9. So the health management information system is supposed to be tracking all of that. Because if you track, you now know to what extent you can plan for programs. So if you have so many children that are not receiving immunization, then you Lubabatu, please mute yourself. Thank you. So you track. So those are what the health management information system. So coming back to what we did. So my organization, we worked closely with the Ministry of Health to use this DHIS2 platform to extract data for all the different health indicators. So for maternal care, for non-communicable diseases, so all sorts. So we do like what we call a quarterly review meeting. So we bring the HMIS officers from the states, some of the states will come to Abuja, and then we work with them. So we have a platform that does some of the analytics in an automated way. So we are also planning to embed AI functionality into the analytical framework so that it makes it a lot easier for data collection, cleaning. For instance, the health management information system, to ensure that data is of high quality. So there are some data quality checks that are made. You want to check, are the people reporting the right indicators? Are they reporting complete? So each health facility has a list of indicators, service-focused indicators they are to report on every month. So you want to check, for instance, is there any particular indicator that is not reported each month? Because it will have an effect on when you aggregate, pull all the data together. So if we see any outliers, so for instance, you expect that in a community, maybe it's a community made up of where they have about 500 children, and then the immunization coverage or children coming for any service, they are reporting 1,000. You know that data is wrong. So it's an outlier. So we have a system that can dictate outliers, and then you want to check the veracity of that data. That's correct. So we have a mechanism where you can do spot checks or from facilities where you're suspecting data is not correct, or you make some calls to the officer in charge, like I said earlier, OIC, to ask, okay, your report says this month we saw so number of children. Can you check your register, original, like the primary data you collected, to check, are you sure of the number? And they can say, oh, okay, maybe it was a mistake due to data entry. So data entry, data cleaning, and all of that, then you analyze. So we worked closely with this M&E division of the Federal Ministry of Health to develop what we call the Joint Annual Review Statistical Data and Report. I will share it with I know it's not focused on rehab, but I'll share it, the draft we have, or what the report we developed is a whole lot, but we have a PDF copy. So I will share it, we will share it through the MRTB for the participants so that you see how the health management information system is used to track progress. So across different dimensions, both financing, for instance, how much are we spending on healthcare? There is a mechanism we call the National Health Accounts where we collate and analyze how much Nigerians are spending as individuals and as government and also donors. So the health management information system is a very robust, comprehensive mechanism for collecting and analyzing data that is health focused. Any questions? So if you look at the slide in front of you, so it says data flows through a systematic approach from the point of collection till when it is being used. So for instance, oh, okay, now I see what the person was asking about. So PAC, it is not SFH. So primary healthcare, PAC is primary healthcare. Then SHF, my apologies, secondary health facility. I hope it now makes sense. So not SFH, but SHF. So the idea is primary care level and then secondary care. So for now, the tertiary hospitals are not connected to the health management information system. So it's mainly data from primary care level states. We also don't get data from the private sector. So the private health facilities do not report through the health management information system for now, but there are efforts to incorporate them. There's what the ministry is working on. It's called the Health Data Digitization Initiative, where they want to digitize, where, for instance, you have electronic medical records connected. So the federal level, the tertiary levels will now be connected to the DHIS. So, but the illustration here is that data is collected at the PAC level or secondary health facility. Then it goes to, so SSHIA is the State Health Insurance Agency. Remember, we were saying that this program, this presentation was, we are focusing on the basic healthcare provision fund. So any data that is health insurance related, the State Health Insurance Authority gets that data from the facility level, collates it, and then on this other side, NHIS is at the federal level, if you remember. But then when we did this program, I think it was 2021. So NHIS changed its name when a new law was set up to, now it's called the National Health Insurance Authority, no longer NHIS. So within the NHIA, there is an M&E unit or division under the Planning, Research and Statistics. So this training we conducted was to train the staff in the M&E division of NHIA to help them develop an M&E framework for the Basic Healthcare Provision Fund, and also for them to monitor all the different activities of the Health Insurance Agency. So when this data is collected, data is analyzed, and now you have the functionality where the data can be is analyzed automatically. No longer, you don't have to use Excel to extract the data and then clean. Now you have some of the functionalities of automated. So they have done some coding, and you can now get the data analyzed quickly and faster. And then when you develop, after you have done the analysis, you now develop a report. So a report that covers all the indicators that you need. So we do a quarterly review meetings where we have what we call the National Technical Working Group on M&E Technical Working Group. So the Technical Working Group meets every quarter, that's every 3 months, to review the data from the states. They make sure that the data is correct and they do the analysis and develop a report. And so we have done 3 quarters. Quarter 1, that's January to March, then April to June, and then July to September. Now you have October to December. So by the end of December, so in January, you will be able to analyze the data for October, November, December. So that is that. So you generate a report, and the report will give an idea of how we are performing across different indicators: service coverage, disease burden, and a whole lot. So, and then when this data, so we try to say, data is important. Data from M&E is important, and the categories of people who should be involved in the process, the beneficiaries, like we said, people who are beneficiaries of our services. So within a hospital, the patients, the relative, and the general public, they should be involved in the M&E process in some sense. So for instance, I did say earlier that one of the indicators that health facilities should be interested in, whether tertiary, secondary, or primary, will be satisfaction. In terms of service satisfaction, are patients satisfied with the services being rendered because it can be an indicator for quality. So we do patient interviews or surveys to ask them about how they feel with respect to the treatment they are receiving. That is an important thing. So it gives you an idea of the quality. So if patients are not being treated well, or it can even be timeliness of service utilization or service utilization surveys or satisfaction surveys can cover different elements. So service satisfaction can have different elements that you can speak about timeliness of the service being provided. So a patient comes, how long does it take for when a patient arrives at the clinic or a facility to the time they see the doctor or the physiotherapist or occupational therapist or the P&O? So timeliness can be measured. And you can also check the cost of services. So patients you may want to survey, okay, if you are satisfied with our services, they say yes. Do you think our services are expensive? They may say, oh, no, it's too expensive, it's or affordable. Because under universal health coverage, services are supposed to be accessible and affordable and also of high quality. So you can have an indicator that measures quality of care provided. You can have an indicator that checks how expensive or affordability of the service, and also even accessibility. So accessibility can speak to timing. So if a hospital is located in Abuja, in the central area of Abuja, but I live in Nyanya or Gwagwalada, so accessibility can mean that if a woman is sick or there's an emergency, so there will be a delay in assessing the care because of distance. So we have some standards about to what extent should a health facility be away from. So I think within a radius of 5 kilometers, you should have a health facility. So we call it geographic access. So geographic access is to ensure that within a geographic area, you should have a health facility to provide for people living within that particular radius, maybe a radius of like 5 kilometers, so that they don't have to go too far away from their immediate environment to access care. So the other people that are also important with respect to M&E are the implementers of a program. So with respect to rehab services, we who are rehab professionals, M&E should be of importance to us because we have a goal, and then we need to find a way to track those. So it's important for us. Program healthcare workers, program staff. So when we say program staff in a setting, so for instance, in a hospital, you don't have everybody that is responsible for service provision. You have the program support staff. So the clerks, the attendants, they support the clinical team. So the clinical team can be seen the ones who are delivering the service, but you have the others whose role, the cleaners, the ones who make sure that the bed covers are clean and all of that. So you have all those components of people. So it may not just be the health worker that is an input. So you have others who play different roles within the rehabilitation ecosystem. They may not be clinicians themselves. And then partners can be people who fund or who have a stake or stakeholders within that. And then, of course, policymakers. So within the healthcare system, the policymakers like the Honorable Minister of Health. So this National Oversight Committee, excuse me. So for the Basic Healthcare Provision Fund, we have a ministerial committee that oversees the implementation. So this committee meets every quarter to review the progress made. So NHIA, the MPACDA, and the emergency, so it has three components of the Basic Healthcare Provision Fund. One managed by the MPACDA and the state primary healthcare agencies, and then the health insurance agencies at the state level with the national one. So they report every quarter to this oversight committee chaired by the Minister of Health. So we've already maybe touched on some of this earlier. So, okay. So now, so one of the things I wanted us to touch on is for rehabilitation management information system. So currently, like many of you know, rehab has not been in the mainstream of healthcare in terms of, for instance, you cannot see in the health management information service utilization with respect to rehab. So physiotherapy care is not recorded, occupational therapy is not recorded, speech therapy and all of that are not recorded in the health management information system currently. But efforts are ongoing globally. Some countries are far ahead where you now have that is embedded in the health management information system. So what is happening is that the NDHS, sorry, the DHIS2, that's the software. So we have those who they are coding to develop a module that will be layered into the existing package for states to be able to incorporate health insurance data. So under health insurance, they have some indicators for tracking insurance or what we call financial risk protection. So for rehab too, WHO has developed a framework for rehabilitation management information system. So the types of indicators, the types of maybe conditions to track, the types of services to track. For those of us who are following the Rehabilitation 2030 agenda, you can read up, just type Rehabilitation 2030, and you'll see a whole lot of information about rehabilitation. So rehabilitation is being integrated into the health management information, into the health system itself. So last year, November, the minister inaugurated a technical working group. So technical working group is like a committee that is now given the responsibility to develop two things, a national rehabilitation policy and strategy. So strategy is the implementation plan. So So that work is ongoing. Professor Yeyemi from Medigri is the chair of that committee. It's a multidisciplinary committee. So he has physiotherapists, he has occupational therapists, osteopathy, audiologists, speech therapists, and yeah, so all the professions that are regulated by the MRTB are all represented in that committee. So currently, a draft of the policy is being developed, and hopefully, I think by next year, the policy will be ready and possibly be approved by the minister and what we call the National Council on Health. So currently, we don't have in Nigeria a rehabilitation-focused health management information system, but it will be integrated. It will be part of this policy that is being developed and strategy. And hopefully in the next few years, we will have one integrated into the health management information system. So I may just pause for now and then to see if there are questions. So are we following? Do you have any questions? Okay, so it looks like we have a question. So let me see. Okay, no questions. Okay. All right. Now, so we have discussed all about so just to recap, we have the health management information system, data collection and all. So just like we have in the research process, so we have two types of data. So we have primary data and secondary data, right? So primary data is the one we are collecting from source. Then secondary data is data that is already collected that you can analyze and also, and it can be true, data can be quantitative, that's like you counting numbers, or it can be qualitative. So for instance, if we want to measure patient satisfaction, we can use like a survey where you have maybe you use a Likert scale, maybe for different questions. So, okay, just like we have the visual analog scale. So the visual analog scale is, so a patient can say the intensity of pain is 5. So like a number, quantitative. But you can also use in terms of qualitative component or dimensions of pain. You may want to, for you to know that it has to be qualitative interview. So you want to ask questions that you record and analyze. So data can be quantitative or qualitative. So for instance, patient satisfaction. If you want to understand, so I mean, we are not doing research now, but you can have a mixed method where for you to have a true picture of the reality you are trying to measure, it's always good to, yes, quantitative can give you quantify the data, but qualitative can give you some breadth of richness of data. So you have done a patient satisfaction survey, and then maybe they say, okay, 20% or 30% or 40% of patients says, oh, we are not satisfied with the quality of services you're providing for so reason. Now, qualitative can help you unpack the why. So why are patients not satisfied? They might say, oh, this. So you can, through qualitative interviews, you can target a few patients whom you now conduct like key informant interview where you want to drill down that phenomenon. So for instance, so why did they say this? Using open questions. So they can tell you more. So, oh, maybe when I come to your clinic, the way they attend to me, maybe they a bit snobbish, or the way they talk to patients, maybe they talk down on patients, or they're a bit impatient. I come to see the doctor or the therapist, and I'm hoping that they will allow me to really explain myself, tell them all the reality I'm facing, but they are talking to me and they are writing, no eye contact, and all of that. So qualitative data can help you get more details, like the nuances of the phenomenon you're trying to measure, or the indicator you are trying to measure. So you can measure indicators being both quantitative and then complementing with qualitative. So like a mixed method kind of way. And then when you analyze the indicator, you can report them using charts, data, like descriptive analysis and all. But you can also do data visualization. So data visualization has become something of importance these days. So I don't know if some of us, I know we can use Excel, generate graphs, the usual and conventional ways, but there are loads and loads of softwares that you can now use to visualize data. So for instance, there's a software called Tableau that people use to generate data visualizations. So rather than using the usual pie charts, histogram, or just line graph, data visualization there are different forms that make so it kind of like humanizes data. So for instance, if you're trying to make comparison between two variables, so maybe patient utilization, maybe women who attend antenatal in one state, you want to compare with another state. So data can be visualized, maybe using the figure of a woman. So the percentage, if it is 25%, it can just be the same woman, but in a smaller figure. And then the percentage that is higher. So using a ratio that compares, so like you're presented to decision makers. So decision makers are a bit impatient. They don't have that time to read the details of the data or the report you are generating. So they want to see so that they can make quick decisions. So the way you report data, the way you package it is an important thing. So you package data in a way that it can be patients too, but the recipient or the target audience should not have difficulty interpreting and understanding the data that is coming from your health management information system, for instance. So this joint annual review that just ended yesterday, when you see the report, you will see that it's relatable, the way it is analyzed and then kind of presented. The presentation using data visualization is an important thing. So it's really an area that we need to also develop some capacity in doing. So data visualization is really important. So in writing a report, I think we all know I think writing a report is not a difficult thing for most of us, but in a report, certainly the ones that have been used to, so you just have maybe you have a summary or an abstract or what they call executive summary. Then you have like introduction, then you state what that report is about. How did you collect the methodology that you used to collect data? What are the findings in terms of analysis when you analyze the data you've collected? And then there's necessarily no discussion because it's not called like a research paper, but what's important is the policy implications of what is coming out from the analysis you've done and conclusions and recommendations. So for a policymaker is interested in, okay, what are the implications of the results? So if, for instance, from our health management information system, we notice that patients are not really satisfied or they are complaining that the cost of treatment is high. So the CMD or the management committee of the hospital might be, so will now be, what decision do we make based on this data? Do we need to reduce the amount we charge for the services, or do we need to ask the government for more funding so that we subsidize services for people, or we put some incentives or get private sector through corporate social responsibility to help us maybe offset some costs? So data, so the point is that monitoring and evaluation is not an end in itself. So the idea is to help you generate data and evidence for decision making. So if in our clinic we notice that patient outcomes are not really improving, it may give us an opportunity to review the protocols that we use for treating patients to see, are we getting everything right? Or are there areas we need to improve, for instance, and all of that? So it's important that the data is for decision making. Data coming from M&E is for you to improve the service you're providing, is for you to check how you are comparing with, maybe for instance, other facilities within the same geographic area. You want to be sure that the quality of services you are providing or the outcome, patient outcomes. So if the patients that have low back pain come and then we use a particular process for treatment, maybe a particular procedure is what we use, and the results are not coming, it may be that we may need to tweak to combine procedures. It may just, maybe we are using only manual therapy or manipulation for treating the back pain patients without adding other modalities. So it could be that we need to maybe tweak the way we are treating patients, So that's pretty much what I wanted us to share about service delivery, performance measures, health management information system, and all of that. So let me pause here to see if we have any questions or comments. So my target is for us to end by 3. Yes. The house is quiet. Please, yeah. So what questions do we have? Okay. Okay, so one more thing that, so we've talked about, let me check what so imputing data into health management information, report writing, record keeping. Okay, so I think I've just touched a bit on some of this, but so what the key takeaway is understanding how the health management information system is structured and how data flows, the type of data and indicators that are collected. Now, the board also wanted us to talk about conducting surveys. Great. So one quick question is, who has conducted surveys that are health related? Can you share your experience with us? Before I talk about some of the surveys that are conducted within the framework of the National Health Management Information System. Have you conducted patient surveys, for instance, or household surveys? Who has any experience conducting surveys? I know our research, people in the academia and research do that a lot, but people within the clinic settings also conduct surveys. So let me know just in the next 2 minutes. You can use the chat box. Yeah, so Ebonluwa Omodara, so your undergraduate research, did it include surveys? If yes, please share with us what type of survey you conducted. Thank you. You can unmute yourself, or you can type in the chat box if you're not in a position to speak. Okay, treatment satisfaction survey. So what were the components? What type of data or indicators did you try to measure? So Ebonloa said that for her undergraduate research, she conducted a treatment satisfaction survey. So I was asking if she can throw more light on what were the indicators or type of data they collected for the survey. Ebonloa, please, over to you. If you don't mind, unmute yourself and just tell us a bit what you conduct, the type of data you collected.
Thank you so much for the wonderful class so far. So my undergraduate work was on treatment satisfaction, particularly of chronic pain patients. So
Okay.
it was a survey which we carried on chronic pain patients who had attended or had physiotherapy sessions for at least 5 sessions, so that they have a long-term view of what it looked like. So our survey was based on 5 key parameters: cost of treatment, accessibility to facility,
Okay.
Patient provider, that's who the physiotherapists. There were some questions on patient provider themselves. There were other interrated factors where it was open-ended for them to impute their own, wherever they thought would have impeded their satisfaction of the entire process. So the survey mostly that most of long-term patients actually towards the 6-7 session, they get lesser satisfaction with their overall treatment. So, and longer time patients, that's patient that's been coming for years, mostly just coming or keep coming because they don't have a choice, but their satisfaction does not really improve. But again, we're not able to tell it if he had issues. Their conditions, because chronic conditions can always have that effect on patients. Maybe they were supposed to be under research on if it was because of the chronicity of the condition or they felt things changed about the way they were treated alongside the long-term treatment period. Thank you.
Yeah, thank you so much. I think this is great. So this is an example of patient satisfaction survey, and they measured treatment quality and a whole lot of things. So this is great. And I think I will also encourage different colleagues in your practice or clinic. It helps to conduct patient satisfaction survey. It could be exit interview. So exit interviews after patient had been attended to, and as they leave, it can be it can be an intern. Somebody asks them, how was the experience today? Are you happy? You can use, so for instance, at Heathrow Airport, when you use at the toilet, you just have, there is a digital like survey that they conduct, not anything complex. So it's like a smile. So if you are happy with um, the 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 service overall, you can just click on smile. If you're not satisfied, maybe a frown, that kind of thing. So they can use like a traffic light system, which is kind of data visualization. So green. So when we track progress, going back to M&E, so when you track progress, you may not have to put the data in a very quantitative way. You can use some visualizations. For instance, there's something when I did mention to you guys that every month we report to our donor. So the donor, for the different indicators that they are tracking, we can use what we call the traffic system. So you have green, red, or yellow. So red is you are off track. So maybe the target you set for yourself, you are far behind. Maybe you're below 50% of achieving that. So that's you are off track. So you can use red, like progress tracker, we call it. Then if you are on course, but you have not reached maybe like 70%, it can be yellow because you are on the road making progress. But if you have reached your indicator or the target, it can be green. So that's traffic light system. So very simple system. There's also what we call scorecard. So some scorecard is where you aggregate the data and present it in a way that it shows. So for instance, for maybe immunization. So the Nigeria Governors Forum, we used to work with them where we develop a scorecard. So across different things. So maybe the number of children in a state that are malnourished, for instance, or the number of children who had, when white polio virus was the major challenge. So we had a scorecard to rank states. So number of children who contract polio every month or throughout the year. So it can just be numbers. So each Kano, Kaduna, Yobe, Borno. So you just rank all the states. So the states with the highest burden, you can just see how it appears. So it helps. So you can just do that instead of putting numbers. It can just be used like a visualization, like a scorecard. A scorecard is like reports. When we were in primary school or secondary school, we used to have like a report card that is like an M&E. So yeah, it's tracking our progress, our academic progress. So you can see that in education from our primary school, we write exams because they are testing our knowledge, what we are taught. So at the end of every term or at the end of every section, we get a report card that shows how we have performed across different subjects. So that's like an M&E report, monitoring and evaluation mechanism for tracking progress academically. The same for health, for economic development, the GDP, gross domestic product, the employment rate, inflation rate. Those are indicators for tracking how a country is performing economically. So we also have what we call the Human Development Index. So it has different indices that track how countries are making progress. So you could see how important data, monitoring and evaluation, because it tells you where the progress you're making and how you are making the progress. Now, coming back to surveys, and I will wrap up with this. So within the health sector, just for you, like I said, I'm coming from the perspective of public health because it looks at health, not just rehab, everything. So we have two major surveys that are conducted. So we have what we call the National or Nigeria Health National Demographic and Health Survey. I'll type it out in the chat box so that you can check it out after this training. Nigeria Health Demographic and Health Survey, NDHS. So this survey is called NDHS. You can check the chat box. So one was just released, I think about last month, the 2024 NDHS. So all countries conduct this, and it's conducted every 5 years, 4 or 5 years. And it measures a lot of key health indicators, maternal mortality. So when you hear that Nigeria's maternal mortality is maybe 500 per 1,000 live births, it's through this NDHS that is collected. So the Nigerian National Bureau of Statistics, NBS, usually leads the work, but together with the National Population Commission. I'm sorry, it's the National Population Commission that conducts because it's a population level work. So, and data is collected from across all the states, NDHS. So they have like a survey plan. So they map all the households. So this random probability sampling they use, and then random selection so they map the households across the country and in each state, and then they select randomly so they go there to collect the information. So they have a questionnaire they use to collect information about so many things. And then they collect all of that data and analyze. And then the report that is presented is called the NDHS report. That's the National Demographic and Health Survey. And you can just Google, I didn't put the link, but just type that, you will see the latest one is 2024. Take your time to read through. It gives you a better picture of the National Health Management Information System. So you can see all the different indicators. So there you will see the maternal mortality ratio. I don't think they included that this year, but child mortality ratio, neonatal mortality ratio, number of women who have access to contraceptives. It's called the contraceptive prevalence rate, the mortality rate across. So the burden of disease burden, like maybe number of people who have diabetes or hypertension, the cancer cases. So all of that, the key things about health, and to some extent, I think they have started including how much people pay out of pocket to access services. So take your time, read through that. Then there's another one called which makes sense, multiple indicator cluster survey. It's called MIX. So MIX kind of alternates with MIX is conducted by the National Bureau of Statistics. So you could see the difference. So the NDHS demographic has to do with population. So NDHS, due to the mandate of National Population Commission, they are responsible for conducting the NDHS in partnership with the Federal Ministry of Health, while the multiple indicator cluster survey is conducted by the National Bureau of Statistics, that's NBS, in partnership with the Federal Ministry of Health. And I think UNICEF usually provides so this one, MIX, MICS, is conducted by the National Bureau of Statistics and in partnership with the Federal Ministry of Health and UNICEF. So it focuses a bit more on maternal and child health-related indicators, whereas the NDHS, that's the demographic, covers more population level, more population level health indicators. So those are two key ones that are of importance. There are other surveys that, for instance, there is a survey that looks at prevalence of HIV/AIDS. So I'm talking of prevalence of HIV AIDS. So when you hear that the prevalence rate for HIV is maybe it's 5% or 1%, so that specific one is done. So there is also specific survey for other diseases like malaria. So there's the malaria indicator survey. So that one focuses on different aspects of malaria. So you can read all of that. Then of interest to us is the survey that focuses on non-communicable diseases. There is also, it's called the STAPES survey, STAPES. I can't remember the last time, maybe I'll check the last time it was conducted, but so the STAPES survey looks at the non-communicable diseases, heart conditions and all. So there are several types of surveys that are done within the health sector. There is another one we do that is called for health financing. It's called the National Health Accounts. So National Health Accounts is another one. It's not necessarily a survey, but we collect data from all the states on health expenditure, then analyze it. So when you hear about the Abuja Declaration that we are supposed to spend at least 10% of our annual budget on health, so we use the National Health Accounts to track how much Nigeria is spending on health in relation to meeting the Abuja target and all. So it's already 3 o'clock. I just felt we should stop here. So you have an idea of the types of surveys that are conducted in the health sector within the health management information system. I've also talked about the foundations of the health management information system, how data flows from the lower level primary health care centers, secondary health centers, to the local government, to the state, and then to the federal. And then earlier we discussed the what is monitoring and evaluation, and discussing about the M&E framework and all. So I think I'll just stop here for now. But for one last word, so for evaluation, like I said, we didn't focus on evaluation. It's mainly the monitoring. So for evaluation, there are different types: impact evaluation, and for some programs, you need to as you're designing the program, you also design how the impact evaluation will be done. So it can be like a randomized control. So randomized control trial is not only for clinical, like you want to test a therapy or a drug. For population level programs or even economic empowerment related programs, there are ways to use the same principles that are used for randomized control trials to do the impact evaluation. So there is cost, when you hear about cost-effective analysis, cost-benefit analysis, or value for money. So those ones are evaluations that look at the benefit you are getting from the program versus the cost, or how efficient the program and all of that. But it's a different topic we can do if it's necessary. I think I'll stop here for now. If there are questions or comments, and then we can wrap up. So, Madam Tole, I was saying, I don't know if you have any information you want to share, but I said that I will share some documents with you that you can, including the presentation, with all the participants so that you can read and refresh.
Yes, sir. Thank you, sir. That would be attached to it, their certificates when it's ready to be issued out.
All right. So do we have any last words? It's already 3 and I know we've been here since 10 o'clock. That's like 5 hours. And yeah, it should be enough for us so that we are not fatigued listening to one person for 5 hours. So in the absence of any questions, I think we can say goodbye. I don't know, but if you want to reach out to me, I'm on LinkedIn. You can use, let me see if I can. So my LinkedIn, you can find me on LinkedIn, and yeah, you can connect with me from there. Or I don't know, but if you have any question that you're not able to ask today, maybe send it to Madam, or I can share my email, or you can reach me via LinkedIn. So yeah. So I've just put, so I'm putting my details there in case some people may be interested. They want to reach me. So, oh, sorry, yeah. So I've just put in my email address and where I work, but if you want to know, my email is just obfelix@gmail.com. So if you have any question that we couldn't attend to today, or you want more information on M&E or monitoring and evaluation, you can reach out to me. And yeah, so thank you everyone for making our time to join us today. And I wish you a wonderful and restful weekend until we connect again.
Thank you
Bye,
very much,
everyone.
sir. And have a wonderful day, everybody.
Okay.
Bye.
Okay, bye.
Yes, sir. You can end the meeting, sir, since you are the host.
Sorry?
I said you can end the meeting, sir, since you are the host, sir.
Oh, I didn't realize I was the host.
Yes,
Okay.
sir. Thank you, sir. Yes,
Okay,
sir.
no problem. Okay, let me end it.